When it comes to logistics po, when it comes to supplies, sad to say, supplies are not on time delivered in our facility and I think in other facilities as well. The disposable gowns, all the disposable things, we reuse them just to maximize the resources.
At patuloy pang nababawasan ang bilang ng ating mga health workers.
Even though you're a graduate of the healthcare course, akot nila na magtrabaho sa hospital. Plus, during this time, sir, nag-open yung different work from home na ang requirement nila is healthcare. Gustong-gusto magtrabaho ng nurse, ng pharmacist, ng doc, ng mga residents, but they opted to finish the pandemic. And then they resorted to alternative work environment or jobs. In a month, meron sa amin during the pandemic, tumaas talaga na nagka-30 to 40 per month ang resignation. May mga units talaga na nagko-close kasi technically kung dating patients na gustong bumalik ng hospital, they resort to telehealth or home care.
Gayunpaman, may kaunting pag-asang naranasan ang isang pribadong hospital sa Mindanao.
Well, actually, during the pandemic, number one, the early phase of the pandemic, there was actually an increase in the resignation. For one reason, only one reason, because they're afraid to go on duty kasi pandemic. Ako, di ba? But when they found out, hindi pala nakakatakot ang Nung bumabalik naman yung mga nurses, di ba? Dumami ng mga nurses.
Ramdam din ang bigat ng kakulangan sa sahod. Ngunit sinubukan itong ibsan kahit papaano sa pamamagitan ng mga non-financial incentives.
Of course, salary ng nurses in the country is still not really that good compared to other international countries. The power of purchasing ng peso. I think we need to base everything from there because, again, basic needs kasi it's one of the challenges of us healthcare worker right now. Incentive, free meals services during that time, especially nung wala yung transportation. Accommodation is also but subject for criteria. Hindi naman kailangan. We even converted a lot of rooms just to accommodate healthcare workers who volunteer to stay in the hospital rather than go home. And of course, 100% subsidy of the benefits for both your family and of course the healthcare worker. In case magka-COVID, sagot yun. So yun ang medyo magandang incentive during the pandemic.
During that time, when they were quarantined, we paid them 24 hours instead of the usual 8 hours. Even during the time that they were quarantined. And then we also give out free meals for those who are assigned in the COVID area.
Whether you like it or not, you have to do that. Meaning ako, like for example, dito meron din, meaning like for example, meron kasi mga financial incentives. Let's say, meron silang added na mga fees, mga ganyan, tapos mga non-financial, for example, yung kanilang admission, free, etc. So, kasi pag walang incentive, wala kang nurse. In the free market enterprise now, you have to be more innovative. So, making sure that you retain nurses, making sure that you have nurses. And then the only, let us say, tangible incentive that will retain our nurses, of course, isa pa rin sa hierarchy of needs, monetary pa rin.
Magkakaiba ang naging karanasan ng mga health workers sa pinansyal na tulong na ipinaabot ng gobyerno.
Most of them are from Luzon. So they said they have already received their OCA 3 months already, 3 or 4 months OCA they have received. But for the province in Negros, we have not received any yet. But in Cebu, I think they received 1 or 2 months. 1 month or 2 months already. If you can see a lot of posts where may finding OCA na sila. Pero may din sila, sir, may mat allowance din, meal, accommodation, and transportation allowance na 3,500.
And
one time lang, one time from September to December, July to December 2021 dapat sana. Yung nabigay sa amin, we reported 1,000 employees, 1,001 I think na. Yung nabigyan lang ng allowance is only 294 employees. So hindi rin lahat nabigyan.
Actually, dito, mayroon talagang delay. Pero ano kasi naman yan, yung ating OCA, at saka sa race for last year, until now, they're not yet
Release.
released. Okay.
Okay.
So even if, for example, nagbigay na kami ng kompleto ng aming mga documentation. So, in fact, other hospitals, wala talaga. Okay. So, kung sa baga, there are two sides of the story kasi meron namang iba dito na hindi talaga sila nabibigyan for the reason na they're not doing their work.
Naapektuhan din ang mental health ng mga health workers.
And then nandun nga yung fear and anxiety, yung worries nila about their families, about their loved ones, yung concerns nila about yung availability ng protection nila, yung supplies, yung PPEs, ganyan. Tapos at that time din, nakita namin yung feelings of uncertainty, yung anxiety, yung low morale, lalo na pabago-bago yung mga policies and guidelines dati, di ba? Dati, in a day, pwedeng magbago yung policies and guidelines about how to do work in a pandemic situation. Tapos, nakita namin yung impact na poor communications, so yung roles and responsibilities, yung having a voice in making decisions. So, yun usually mga nakukuha namin na concerns when we talk to our nurses. Nakita namin is consistent yung mental health concerns talaga nila nandun from the start of the pandemic up until even ngayon na post-pandemic na. So dati, fear and anxiety nga, uncertainties nga. No? Ngayon, ang issues naman natin, burnout, exhaustion, na, or depression na. So yun na yung mga problems na na-encounter namin.
Paano pa natin masusuportahan ang mga health workers?
Okay, as a health worker, particularly is number one is we must have, of course, support in place, no? Both sa stakeholders, sa lahat ng members of the organization, kami as a healthcare worker, so that we can be able to perform yung job na ini-expect sa atin to address the pandemic. So the support is probably we can benchmark doon sa basic needs natin as a human being from physiological and holistically.
Simulan natin ang pagtalakay sa iba't ibang issue at hamon na kinakaharap ng mga Filipino health workers. Bibigyang buhay ang mga boses ng mga health workers, government representatives, ang pribadong sektor at ang mga labor and professional groups sa Policy Dialogue on Supporting Frontline Health Workers' Resilience and Retention Beyond the Pandemic, November 10 at 11 sa Conrad, Manila. Ang dialogong ito ay hatid ng University of the Philippines Manila College of Nursing, a change agent serving the health needs of the Filipino people. The COVID pandemic has changed our world. With almost 4 million COVID cases and over 63,000 deaths in the Philippines, the pandemic has also affected our mental health. 33% experienced anxiety and 28% suffered from depression. And in a cross-sectional study among Filipino healthcare workers, 71% had anxiety symptoms and 51% exhibited depressive symptoms. How we view and practice healthcare also changed. In the first 18 months of the pandemic, 115,500 healthcare workers died from COVID-19. This was highly related to a systemic lack of safeguards. There was stigma against healthcare workers. They experienced discrimination. 26% experienced coronaphobia, and 21% expressed they want to leave the profession. In the Philippines, about 40% of nurses in private hospitals have resigned since the pandemic began. Although there are no official numbers yet, there are numerous reports of resignations in public hospitals as well. Systemic support is severely lacking. With inadequate pay, unsafe working conditions, shortage of human resources, and lack of social recognition. Where do we go from here? How can we support our frontline health workers? How do we promote retention and resiliency among our health professionals working in the country? How do we provide quality care in this changed world? We can start by engaging decision makers and stakeholders. The policy dialogue on supporting frontline health workers' resilience and retention beyond the pandemic is happening on November 10 and 11 at the Conrad, Manila. Government representatives, private sectors, the labor and professional groups will converge to discuss issues affecting the health workforce. This event is organized by the University of the Philippines Manila College of Nursing, a change agent serving the health needs of the Filipino people. Kakaibang hamon ang hinarap ng mga health workers natin dito sa Pilipinas dahil sa COVID-19 pandemic. Paano ito tinugunan ng mga health workers sa iba't ibang parte ng bansa? Pakinggan natin ang ilan nilang mga pahayag.
Many changes were instituted here in the hospital, especially in the way we do things. For example, attending to patient. Before, kahit walang mask, we can do that. But after the pandemic, hindi na. And then also a very limited face-to-face interaction with patients. Another noticeable change in the institution, mas na-utilize yung electronic medical record. Before the pandemic, written lahat papers yung medical records, and when we do request for laboratory, talagang through paper request. But during the pandemic, everything digitalized na, even yung mga information sa mga patients, we can just view them on the computer.
Everyone is not familiar with the disease, and almost everyone is not willing to take care of the patient, and you really have to convince them, educate them. While we're taking care of patients, we're also running a lot of continuing ed for them to know about the virus update every now and then.
Dagdag pa sa panganib ng di pa nakikilalang COVID virus noon ang kakulangan ng manpower at suporta.
In a 10-bed capacity hospital, supposedly it should have a 30 nurses, but in our case, we only have 4.
So,
set up.
4 lang kayo ngayon, pero 30 dapat.
13 dapat, based on the
13.
DOH. Yes, ma'am, based on the DOH protocol. I am currently as designated as Chief of the Nursing Services. Just a portion of the administrative functions, I'm doing it for the nursing services only. At the same time po, bedside nurse.
Pero kasama ba yan sa original designation mo or ginagawa mo lang yan dahil understaffed kayo?
Ano po siya, ma'am, parang on top of my bedside nurse duties.
So hindi posisyon ang Chief of Nursing Services?
Hindi po, it's just a designation po. It is expected for us to double on our job, to double time, to parang we are expected to be exhausted.
Recording
po.
in progress.
Manpower, wala pong nadagdag na support from manpower. When it comes to logistics po, when it comes to supplies, sad to say, supplies are not on time delivered in our facility, and I think in other facilities as well. The disposable gowns, all the disposable things, we reuse them just to maximize the resources.
At patuloy pang nababawasan ang bilang ng ating mga health workers.
Even though you're a graduate of a healthcare course, apat nila na magtrabaho sa hospital. Plus, during this time, sir, nag-open yung different work from home na ang requirement nila is healthcare. Gustong-gusto magtrabaho ng nurse, ng pharmacist, ng doc, ng mga residents, but they opted to finish the pandemic. And then they resorted to alternative work environment or jobs. In a month, meron sa amin, during the pandemic, tumaas talaga na nagka-30 to 40 per month ang resignation. May mga units talaga na nagko-close kasi technically wala rin patients, sir, na gusto bumalik ng hospital. They resort to telehealth or home care.
Gayunpaman, may kaunting pag-asang naranasan ang isang pribadong hospital sa Mindanao.
Well, actually, during the pandemic, there are No, say, number one, the early phase of the pandemic, there was actually an increase in the resignation. For one reason, only one reason, because they're afraid to go on duty kasi pandemic. Ako, di ba? But when you found out, hindi pala nakakatakot ang ano. Nung bumabalik naman yung mga nurses, di ba? Dumami ng mga nurses.
Ramdam din ang bigat ng kakulangan sa sahod, ngunit sinubukan itong ibsan kahit papaano sa pamamagitan ng mga non-financial incentives.
Of course, salary ng nurses in the country is still not really that good compared to other international countries, the power of purchasing ng peso. I think we need to base everything from there because, again, basic needs kasi it's one of the challenges of us healthcare worker right now. Incentive, no? Free meals, services during that time, especially nung wala yung transportation. Accommodation is also but subject for criteria. Hindi naman kailangan. We even converted a lot of rooms just to accommodate healthcare workers who volunteer to stay in the hospital rather than going home. And of course, 100% subsidy of the benefits for both your family and of course the healthcare worker in case magka-COVID. Sagot yun. So yun ang medyo magandang incentive during the pandemic.
During that time when they were quarantined, we paid them 24 hours instead of the usual 8 hours. Even during the time that they were quarantined. And then we also give out free meals for those who are assigned in the COVID area.
Whether you like it or not, you have to do that. Meaning ako like for example, dito meron din, meaning like for example, meron kasi mga financial incentives. Let's say, iba meron silang added na mga fees, mga ganyan, tapos mga non-financial, for example, yung kanilang admission, free, etc. So, kasi pag walang incentive, wala kang nurse. In the free market enterprise now, you have to be more innovative. So making sure that you retain nurses, making sure that you have nurses. And then the only, let us say, tangible incentive that will retain our nurses, of course, isa pa rin sa hierarchy of needs, monetary pa rin.
Magkakaiba ang naging karanasan ng mga health workers sa pinansyal na tulong na ipinaabot ng gobyerno.
Most of them are from Luzon. So they said they have already received their OCA 3 months already, 3 or 4 months OCA they have received. But for the province in Negros, we have not received any yet. But in Cebu, I think they received 1 or 2 months. 1 month or 2 months already. If you can see a lot of posts where may finding OCA na sila. Pero may ano din sila, sir, may mat allowance din, meal, accommodation, and transportation allowance na 3,500.
And
one time lang, one time from September to December, July to December 2021 dapat sana. Yung nabigay sa amin, we reported 1,000 employees, 1,001 I think Yung nabigyan lang ng allowance is only 294 employees. So hindi rin lahat nabigyan.
Actually, dito, meron talagang delay. Pero ano kasi naman yan, yung ating OCA, at saka sa race for last year, until now, they're not yet
release.
Release, okay. So even if, for example, nagbigay na kami ng preto ng aming mga documentation. So in fact, other hospitals, wala talaga. Okay. So, kung sa baga, there are two sides of the story kasi meron namang iba dito na hindi talaga sila nabibigyan for the reason na they're not doing their work.
Naapektuhan din ang mental health ng mga health workers.
And then nandun nga yung fear and anxiety, yung worries nila about their families, about their loved ones, yung concerns nila about yung availability ng protection nila, yung supplies, yung PPEs, ganyan. Tapos at that time din, nakita namin yung feelings of uncertainty, yung anxiety, yung low morale, lalo na pabago-bago yung mga policies and guidelines dati, di ba? Dati, in a day, pwedeng magbago yung policies and guidelines about how to do work in a pandemic situation. Tapos, nakita namin yung impact ng poor communications, so yung roles and responsibilities, yung having a voice in making decisions. So yun usually mga nakukuha namin na concerns when we talk to our nurses. Nakita namin is consistent yung mental health concerns talaga nila nandun from the start of the pandemic up until even ngayon na post-pandemic na. So dati, fear and anxiety nga, uncertainties nga. No? Ngayon, ang issues naman natin, burnout, exhaustion, na or depression na. So yun na yung mga problems na na-encounter namin.
Paano pa natin masusuportahan ang mga health workers?
Okay, as a health care worker, particularly is number one is we must have, of course, support in place, no? Both sa stakeholders, sa lahat ng members of the organization, kami as a healthcare worker, so that we can be able to perform yung job na ini-expect sa atin to address the pandemic. So the support is probably we can benchmark doon sa basic needs natin as a human being from physiological and holistically.
Simulan natin ang pagtalakay sa iba't ibang issue at hamon na kinakaharap ng mga Filipino health workers. Bibigyang buhay ang mga boses ng mga health workers, government representatives, ang pribadong sektor at ang mga labor and professional groups sa Policy Dialogue on Supporting Frontline Health Workers' Resilience and Retention Beyond the Pandemic. November 10 at 11 sa Conrad, Manila. Ang dialogong ito ay hatid ng University of the Philippines Manila College of Nursing, a change agent serving the health needs of the Filipino people. The COVID pandemic has changed our world. With almost 4 million COVID cases and over 63,000 deaths in the Philippines.
National Policy Dialogue on Supporting Frontline Health Workers' Resilience and Retention During the Pandemic and Beyond. This is led by the University of the Philippines Manila College of Nursing, a WHO Collaborating Center for Leadership in Nursing Development, and supported by Johnson & Johnson. This aims to put together policy bundles and recommendations to promote health worker retention and resilience. Good morning, everyone, to our attendees, panelists, and speakers live at the Conrad Roosevelt Rooms, and to all of our viewers on University of the Philippines Manila official Facebook page. I am Associate Professor Jennifer T. Pagyo, and I will be your moderator for this morning's plenary. Please engage with us by posting comments on the Facebook live stream through the official pages of the University of the Philippines Manila and the UP Manila College of Nursing. Or you may also tweet and tag us at UP Manila Online with the hashtags on your screen, hashtag Health Workers Matter and hashtag Health Workers Matter PH 2022. We've consolidated your comments and questions, and we do raise them during the open forum. So to begin our Day 2 activity, let me just present a little bit on the recap of Day 1. So let's have a quick recap. Chancellor Padilla of UP Manila opened our event by echoing the commitment of the university and urging networks and partners to take care of health workers. In particular, she emphasized the importance of basing policies on updated and accurate numbers reflecting the state of health human resources in our HRH. The WHO also presented the global and regional perspectives in relation to HRH and healthcare system response. Mr. Torres explained how the pandemic reinforced the critical role of the health workforce in achieving universal health care and ensuring resilient systems. The chronic underinvestment and protection of the HRH has created this current context. This was followed by our first panel discussion focusing on the impact of COVID-19 challenges, the proposed solutions in supporting, retaining, and maintaining our human resources for health during the pandemic. Our first panelist was Dr. Vergere of the Department of Health. She summarized the challenges both of the department and documented experiences of the Filipino health workforce. She presented the ongoing and upcoming activities, initiatives, and measures of the Department of Health. She also affirmed the commitment of the DOH to the health human workforce through legislative measures and implementation and monitoring of policies. This was followed by Dr. Kalimag of the Philippine Medical Association. Dr. Kalimag advocated for our physicians in the workforce and presented the prevailing challenges among this cadre. She emphasized the negative impacts of unsafe workloads and the dire need for healthy work environments. PNA President, the Philippine Nurse Association President Miranda, representing the largest composition of the workforce, underscored the current state of Philippine nursing and called for the urgent enactment of the new comprehensive nursing bill to ensure responsive policies for nurses across practice settings. Finally, EMAP Executive Director Gomez poured the sentiments of Filipino midwives. She called out the lack of implementation and monitoring of existing policies and reached out to partners and the Department of Health to ensure implementation of current legislation. This was followed by an open forum that expounded on the following topics. We covered salary standardization, release of benefits, initiatives of the professional boards, the DOH peri-pandemic response, and WHO recommendations. I hope you were able to tune in and participate in that very engaging open forum. After we finished our live stream yesterday, we continued the rest of the afternoon by having our roundtable discussions. 3 groups composed of government agencies, professional organizations, local chief executives, donor agencies, and of course, frontline health workers, professional regulatory boards, educational organizations, and hospital administrators talked about lessons learned from the pandemic and preparing for the next. So if you were not able to catch us yesterday during our live stream, you can still watch the proceedings of yesterday's day 1 on the UP Manila official Facebook page. Because it's a live stream, you can still view it and it's still available. Comment, please, on the UP Manila Facebook page, tweet, use our hashtags so you can engage with us here at the Conrad. So let us now proceed to our panel discussion this morning. If yesterday was talking about, the context of the problems experienced during the pandemic, initiatives, and the concerns of the boards and the Department of Health, we are now going to focus on addressing existing issues of health worker retention. We have a rich panel for you this morning, so please stay throughout the activity. To address our question on existing issues of health worker retention, we have 4 topics for you this morning. To begin, let us talk about universal health care in the context of HRH issues. With us today is retired professor of the University of the Philippines, Manila, College of Public Health, and the project director of HRH 2030 Philippines. Please, let's all welcome to the podium and to the virtual stage, Dr. Feli Marilyn E. Lorenzo.
Thank you very much for that introduction from yesterday to today. I was tasked to share with you what is now going on with UHC to provide a context for the rich RTD, the roundtable discussion that we will have this afternoon. So I am sure. Okay. I am sure that some of what I will say this morning will be old hat to some of you, or some of you may know everything that's what's happening. But we wanted, I was asked by the organizers to present this, to provide a beginning common platform for our discussion. So what we will be doing is actually refresh why we are using or why we have embarked on universal healthcare and are committed to it. We will, of course, look at some salient law provisions and principles, and we will emphasize HRH perspectives. And then I just got recent updates from DOH, care of USEC Ken Ronquillo, my partner in crime in all of this. And so we will give you a timeline of the UHC implementation. And the reason for that is we wanted to convince everyone that we are in a critical phase of urgent implementation of universal healthcare, or else lose the opportunity to embark on it at all, no, in our country. And then, and this is what I asked Doc Ken to share with us, the health sector strategy from 2023, next year, to 2028. Okay, so maybe we should ask ourselves again, no, in order for us to be spurred into action, why did we embark on why did we embark in UHC in the Philippines in the first place, no? And we can summarize this in 3 points. First, we had subpar health system performance and poor health outcomes prior to UHC, and even now, no, that we have not really implemented it. And I'll show the evidence for this in a while. We also have inequitable distribution of health services. If you happen to live in a rich area, then you're good. You have access to health care. But if you manage to be born in JIDA areas, then that's just your bad luck. No, you have to walk several hours to go to the nearest health care facility. And the ending of this is that we have poor access to basic quality health care for the Juan and Juanas of the Philippines. No? So what is the evidence of this? The Philippines' health outcomes have improved over the years, no doubt, but not enough to attain targets. No? Our achievements have been so slow. So look at this, that on the last column, you have the 2022 targets, and we have the outcomes listed on the left column. And look, no, for average increasing life expectancy from 2000 to 2005, average Filipino can expect to live 67 years. But in 2020, we managed to increase that, inch our way up to 72, and we're on target for that. But the rest has been slow decline. No? Look at maternal mortality ratio. The target is to decrease this from 126 to 90 per 1,000 live births. And we have not achieved that. We only have achieved 105 maternal deaths in 1,000 live births. We wanted 90. Slow decline in infant mortality rate also. So we wanted to target the decrease from 35 infant deaths per 1,000 live births to 21 only. But the target is 15. Tuberculosis for communicable diseases is the same. No, we wanted to target 427, but we only managed to reach 539 in decrease. And in stunting among children, which is one of the most worrisome outcomes, because this will affect the next generation, we have not reached the target of 21.4% reduction of stunting. No? So we have not done so much. Now, these are slides from one of our old studies, but just to show you, okay ba yun, no? Yung pace natin. And our data has been showing we have really declined over the years. Look at 1970 achievements. The Philippines is the red line. We were the best in all of these outcomes I'll show you. We had the highest life expectancies among Thailand, Vietnam, and even looking at the world global median. But in 2010, 2012, we were already at the bottom. The slopes of change of Vietnam and Thailand were steeper, and the world also did better than us. No? So the question is, why did that happen? The same story in infant mortality rate. When we started in 1970, we had the lowest infant mortality rate. When we ended up in 2012, we had the highest mortality rate. And this is not only the countries that we compared the Philippines to, dear friends. We had other countries, but for presentation's sake, we only chose Thailand and Vietnam to show you. But our shock when we did this was we were the best in the 70s and we became the worst in the 2012 era. No, I know there were a few people that got mad at us for doing this, but we had to show them what it was. The last one is maternal mortality ratio. In 1990, during the evolution, we had the second best maternal mortality ratio in the comparison countries. And look at where we were in 2013. We had the highest maternal mortality ratio. So looking at that, friends, we now will ask ourselves, if we let this to continue happening in the Philippines, what will become of us? No? And why is this happening? So a quick look again at the top burden of diseases. On the left side is the top leading causes of morbidity, and you'll see that most of these are communicable. Only hypertension is non-communicable. But on the right side, the causes of mortality, the causes of deaths, most of these are non-communicable and needs chronic care. While on the left, we only need episodic care. No? So you can see the top leading cause of mortality. And this is January 2022 preliminary data of the Philippine Statistics Authority. So we're looking at what is happening right now, no? The newest data we have. Ischemic heart disease, cerebrovascular diseases, and so on, until chronic lower respiratory diseases. Friends, those that we can actually target with integrated NCD care that is chronic and that you should begin to care for when the first signs happen at the primary level. You cannot wait until they have developed the complications. In addition to all of that, hospital beds and doctors are available mostly in well-off areas of the country. No? Our target for the provision of hospital beds is 2.7 beds per 1,000 population. And look where we are in all regions of the Philippines. Only NCR has come close to 2.08 beds per 1,000 population, and we did not even breach the target, no, or reach the target. The availability of physicians and poverty incidence of 2018 also shows that you have the axis here is poverty incidence on the x-axis and population on the y-axis per 15,000 population. And you'll see that where the areas are wealthier, you have more beds, no? Physicians, I'm sorry. And then also you have San Juan here in Metro Manila that has the highest number of beds per population. The Philippines, that red dot in somewhere in the middle. And you will see Maguindanao as on the right side under the 50% poverty incidence, Maguindanao, as having one of the fewest physician, but with the highest poverty incidence. So where is justice in this? No, if you're poor, then you don't deserve a doctor. That's the way, or maybe you can extend that to health workers because the doctors are what we use that to actually be a statistic that will speak for the rest of the health human resources, even though it's not that precise. In addition, 50% of the population, of our population in the Philippines, do not have access to a primary health care facility. So eyeball all these red areas, no, that have no access. And when we say no access, they're more than 1 hour from a health facility, or the health facility services are too expensive for them, or they do not feel they are welcome with cultural inaccess. And then look at the right diagram. Even prior to the pandemic, DOH hospitals were already congested. This green line here is the ideal rate of bed occupancy rate, only about 80 to 85%. However, you'll see that some hospitals, some regions have as high as 192% occupancy rate. So it was our hospitals were already congested even before COVID-19. So it was not COVID-19 that caused all of these. So yesterday we talked about this, no? That COVID-19 shone the light to the gaps in the health sector, but they were there already, no? So we'd like to talk about this afternoon. What can we do and which can we target? Obviously, we cannot work on everything. So what were these gaps? Ill-prepared individuals and communities for preventive care and hygiene. We don't want to be service deliverers to everyone. We want them to participate in their care. Homes, workplaces, and schools not built to support healthy behaviors. There were elementary schools shown to have no hand washing facilities. In the health sector, lack of epidemiology and surveillance at the local level, lack of COVID testing capacity, poor availability of data, inflexible regulatory framework for laboratories and facilities, no local production capacity for vaccines, drugs, diagnostics to help us with our COVID-19 response, and fragmentation in the supply chain so that there were stockouts for drugs. It was also found that Filipinos had no existing relationship with the health system, no general practitioner or no health worker that was assigned to them, or they knew that they could go to them all the time, no, when they needed care or when they had questions. Not like in other countries, you have a primary provider that you know of. We also have an underdeveloped primary care system limited to the public sector. The private sector is large, but largely there is a loose relationship between the public and the private care system, if at all. And of course, we have a lack of hospital beds and ICU capacity, as what was shown during COVID-19. You know, we had tents to house our COVID-19 patients. Some died before they could even get to the formal ICU or even inside the hospital. So there was also technical and leadership capacity of managing institutions that were limited. So this led to fragmented control and capacity on the ground, and interagency coordination not institutionalized. No? So we knew who were our partners for COVID-19 response, but somehow the coordination was not institutionalized, and we ended up pointing fingers at each other who did not do what they were supposed to do. And I guess, you know, our friends from DBM, the Department of Trade Industry, Labor, they were all also pointed to as not doing their job. And then health workers were generally underpaid, overstretched, and mentally stressed workforce during COVID-19. And to top it all, there was pandemic brain drain. A lot of health workers said, I've had enough, I need to go out. No? So we talked about many of these yesterday. So after that, what needs to be done? We have to have a critical mindset and priority shift. No? Unfortunately, we've had RA 11223 or the UHC law. But what are the priority shifts? No? From health services as the only means to improve health outcomes to intersectoral collaboration for health is necessary, meaning we cannot improve the health of our people alone in the health sector. Chronic underinvestments in health, which has been the story of our lives for decades, to increased investment in health. Inefficient and uncoordinated healthcare management to providing right care at the appropriate level. So if you don't need hospital services, why do you go to the emergency room of the hospital and clog it up? The statistics say only 5% of the population at any time need hospital service. But 95% of the time we have minor health problems or health questions for our families. So why? Baliktad tayo. We have a hefty hospital level, but we don't have a good primary care system that our people need. So again, another one is organizational strengthening was never a deliberate agenda in the past. But now we must build management institutions for health as a priority. And then for health workers, of course, there was inadequate provision of health worker compensation, as has been the complaint, and you saw that in the video, to adequate provision of healthcare worker compensation. The mindset change is also that we need to address health determinants because this will yield better health outcomes. So hindi puro gamot, hindi puro ospital, no, ang kailangan, but we need to pay attention to these health determinants. What are these? Socioeconomic factors, education, jobs, family and social support, income, and community safety. That makes up 40% of whether or not one will be healthy. No? 10% physical environment, the buildings we live in, the homes that we have, whether they're made of sturdy materials, whether we have green trees around us or clean air and clean water. That's 10%. Health behavior makes up 30%. These are direct determinants. Tobacco use, alcohol use, diet, exercise, and sexual activity for HIV/AIDS. And only 20% that will be determined by health services or access to care, quality of care. So if we look at this, we will really change the way we're delivering health, no? Healthcare, to look at those factors and hold hands with our partners in all of society, all of government approach. So our intervention areas will be healthy public policies, healthy settings in schools, communities, and workplace, health facilities, medicines, and equipment available in health services, and this should be always, no? Hindi yung pupunta sa RHU, minsan may gamot, minsan wala for hypertension or diabetes. Human resources, always there, and the law says that they must be, every Juan and Juana must be attached to a primary care provider. No? So si Lynn Lorenzo, alam ko kung pupunta ako kay Nurse X, pag may questions ako or pwede ko siyang tawagan kung bigla ako nagka-allergy. And health financing is very important because that will drive everything. So what is our vehicle then? It's the UHC law that we are talking about here, RA 11223. So for those of you that can't remember this, just remember it's as easy as 1, 2, 3. No, it's 1, 1, 2, 2, 3. The principles are integrated and comprehensive approach, no, to healthcare to ensure, first of all, health literacy of Filipinos. No, yung iba, baski yung blood pressure readings, hindi nila alam yung difference between systolic and diastolic and what it means. Healthy living and protection from hazards and risks. And then we need a healthcare model that provides comprehensive health services without causing financial hardship. Yung di ka matakot na pumunta sa hospital dahil lahat ng savings mo mauubos. Whole of system, whole of government, and whole of society approach in the development of health policies. And this is what we're talking about this afternoon. Yeah. People-oriented approach, and this is where UHC, Universal Healthcare, will bank on getting people participating on their own healthcare provision. No? So, kung hindi acceptable sa kanila, kung hindi nila gagamitin, dapat hindi i-provide. Okay. Go ahead. Just as an aside, no, you are seeing our UHC, and UHC in the Philippines, friends, is called Universal Healthcare. In other countries, UHC is Universal Health Coverage. Universal Health Coverage mostly refers to insurance coverage. But when we were working on the UHC law, we said universal health care is more than just accessing insurance. No? So that's why the Philippines has insisted over the years, and WHO has been egging us to change our name, the way we call it, to coverage, and we have refused because we wanted to focus on the care. Kasi yun yung kulang natin. Okay? So, yeah. Okay. Okay, so principles, quickly. Population coverage, baka alam nyo na ito, no? What does universal healthcare mean? Automatic inclusion of every Filipino, kahit saan ka man, from Batanes to Tawi-Tawi, of every Filipino into the National Health Insurance, PhilHealth. Service coverage, immediate eligibility and access to population and individual-based health services. Walang waiting period. Hindi gaya nung araw, you have to be a PhilHealth member for 6 months. Ngayon, once you're at the point of care, you must be able to reap the benefits of that. So under the law, UHC provides important changes to the Philippine healthcare system with regards to population, service, and financial coverage. So, financing. Population-based health services is funded by the national government, and individual-based health services primarily through prepayment mechanisms. Yung social health insurance, which is PhilHealth, private health insurance, and HMOs. So lahat yan dapat covered. Walang rason na walang mako-cover. So yung ating mga kababayan, if they were not covered before and they go to a hospital or they go to an RHU, meron na ngayong point of service membership, no? So pwedeng pag nandun ka, doon ka na i-register, and at that point you can enjoy the benefits of PhilHealth membership. Okay, so it's simplification of the National Health Insurance program into direct and indirect contributors. Noon, masilimuot yan. Meron pang yung direct contributors, meron pang subsidized indigents, marami pang classifications. Ngayon, wala na. Pooling of funds for PhilHealth for all individual-based health services. Yung mga consultations and not population. So the NHIP will give us entitlements to benefits. Our patients can now expect immediate eligibility. PhilHealth IDs will no longer be required in the availment of services. Basta may makapakita kang ID na ikaw ngayon at ikaw ay Pilipino, there will be no co-payment in basic or ward accommodation. So yung no balance billing also is part of that. Service delivery, there are two. Population-based health services, DOH to contract province and citywide health systems with the following components, no? Primary care provider network, epidemiologic surveillance systems, and health promotion programs and campaigns. The other one is individual-based health services. Ito yung PhilHealth to contract public, private, or mixed healthcare provider networks that will provide services to individuals. So they must assure service quality, co-payment, co-insurance, and there must be patient records for data submission. No? So PhilHealth, in short, integrates and reorganizes our local health systems. But why is there a need to do that? No? We had devolution since 1990. But we have inadequate instruments to assign accountability and coordinate with LGUs. So we had weak local capacity to manage health systems. Ang ending niyan ay poor health systems performance. Wag na natin pag-usapan yung iba kasi masalimuot pa din yun. But that's why we need to reorganize local health systems. Kasi kung patsi-patsi, tsaka dissonant yung mga LGUs, like in the past, yung governor, the mayors took care of the RHUs. Kung magkalaban sila, paano yun? So hindi na marirefer, wala nang back referral. So that should not be allowed to happen. So we now integrate health systems into province-wide and city-wide systems to harmonize the efforts to ensure efficient delivery of health services. Local health systems will be integrated into these systems. Then you are governed by provincial city health boards, oversee the integration of health services. So ngayon, it's not just the provincial governor or the mayor that will lord it over. No? Dati, pagka hindi kapartido ng mayor yung MHO, talsik siya or freezer siya. Pero because now you have more people, the health board hopefully that will attenuate the decision making and make it easier for the health staff. Municipalities and cities are entitled to have a representative in the provincial city health board, no? So mas ano yan, mas participative. And then the local health systems enable income retention for all public providers through a special health fund. Na yan ang isang masalimuot, and we hope the DBM will also shed light on this. Income derived from PhilHealth payments accrue to the special health fund, and incentives that we were talking about yesterday through financial and non-financial matching grants will improve competitiveness of the public health delivery system. So in diagram, we will get a lot of funds for the special health fund from national government subsidies, PhilHealth income, ODAs, NGOs, and other financial grants and donations, no, and LGU budgets from the ERA. Saan pupunta to? Remuneration of additional health workers and incentives for all health workers. And that's why we're banking on the special health fund. Health system operating costs, improvement of the facilities and capital investments, and population and individual-based services like the vaccination that we had under COVID-19. This should now be governed by a special health fund utilization tracking system. Kasi ano yan loose fund na pwedeng pumunta kung saang-saang bulsa. No? So we need to track that. So we will digress for a while and look at the human resource for health perspectives. We look at reorientation of the health human resources to UHC that we talked about yesterday. Some curricular changes, practice-ready HRH and the HRH information system that are needed for UHC. No? So for human resources for health, in the UHC law, it provides for the National Health Human Resources Master Plan. That has been done, check. The National Health Workforce Support System, we're building that up right now. DOH is building it up. The Scholarship and Training Program, including Return Service Agreement, this has already been promulgated, but it's being developed right now. So anyone receiving government monies for training will be required to give back at least a 2-year return service, no? And at the University of the Philippines, they have been doing this as an experiment for a number of years now. The National Health Human Resource Master Plan shall be if you will, the blueprint, no, for what is being doing. And this is what the DOH is trying to implement with all the other government agencies. Okay, now let's go into the reorientation. Yesterday, people were saying, dapat ma-retrain ang mga health professions so alam nila yung UHC. So there's now a part in RA 11223, Section 25 that specifies for this. Changing the curriculum, reorienting the healthcare professionals, and determine the recommended areas of study in public health to be incorporated in the curriculum of all health sciences education. So even among the dentists, the PTs, mga radtech, lahat yan dapat may UHC, not only the doctors, nurses, and midwives. And we have to incorporate educational outcomes focusing on primary care in the education programs, including the scope of licensure exams, continuing professional development programs for health workers, and certification programs for healthcare workers. So lahat UHC-based, UHC-reoriented dapat in the ideal sense. No? So merong joint administrative order between CHED and DOH to establish guidelines for reorientation, install implementation mechanisms, and define the roles of CHED, PRC, and DOH. So nagawa na yan. And here, I just wanted to specify, kasi ang question ay, anong ilalagay mo sa curriculum? Is it primary care orientation or primary health care orientation? Those of you in academe here know that this is a sticky discussion. but the focus is reorientation to primary healthcare. And as you can see in the Venn diagram at the left side, primary healthcare is the larger area, which is the approach. And primary care only pertains to a specific level of care provision at the point that is closest to our communities and clients. No? So we have to focus on primary healthcare. Primary healthcare policy framework and sectoral, you see that there are examples of what falls under primary care, population-based, and what goes under individual-based or personal care. Okay, so this is the healthcare provider network concept that was also discussed yesterday. No, so you have different levels. You have primary care, secondary care, and tertiary care. However, they must all be connected in the UHC era. Hindi na sila pwedeng stand-alone tertiary hospital or stand-alone RHU. No, so for most concerns, which I said a while ago was 95%, you can go or everyone and Juana must have a primary healthcare station. Yung tinatawag nating barangay health station sa rural areas. Sa city naman, ito yung kanilang healthcare facility. Tapos may primary healthcare facility. Usually this is the RHU or the city health office. And then you have a complete, comprehensive set of services that may be contracted. So yung primary healthcare facility mo pala can either be public or private. No? So kung malayo masyado yung RHU, kung may malapit na clinic or polyclinic, pwede kang pumunta doon. Now, what will it look like? Guys, our RHUs will become super RHUs. Kasi dapat may diagnostics na sila. What is being told to them is that kung ang leading cause of mortality natin is NCDs, then they must be able to diagnose and have labs for NCDs. So, ang tinatawag nga yung iba, like in Quezon City, super health centers. So, kung wala silang labs, wala sila kunyaring ultrasound, they can contract those services from a private provider. No? So, but that's why they are networked. Dapat kabit-kabit sila. So, you can imagine the amount of coordination that entails. At the second level, then you have level 1, level 2 hospitals and other facilities. And you have level 3 hospitals. And then this will all be connected to an apex or end referral hospital, which can be standalone. And yesterday, the example was PGH, or the regional hospitals of DOH in every region that has a heart center, a cancer center, a kidney center, and all that. So there are now specific guidelines to reorientation of primary health care that will include changes in the curricula, faculty development, student internship or placement programs. For PRC, there has to be a new table of specifications for licensure examinations. There will be student orientation and immersion programs. And finally, the return service obligations will have to be implemented. Now, this is critical, guys, because we are not keeping our young graduates from leaving the country. Di naman. They're only being asked to serve for 2 years, no? 3 at most for some courses. And that will only be used to stabilize our health human resources. After 3 years, they can go wherever they want to go. No? And if they look at it strategically, this is also experience for them, bayad pa. Kaya lang, DOH will have a hand in saying saan sila pupunta. Kung saan sila mas kailangan, of course, there will be more placements for those areas. And yun yung ayaw ng ibang magulang, ayaw din ng ibang students. But in our experience at UP, they're just too excited to learn about the rest of the country and go to wherever they're needed. No? Kaya lang, our system has to provide safety and security and a working environment that will not frustrate them. Kasi can you imagine, pupunta ka sa isang liblib, tapos andun ka nga, pero wala kang gamot, wala kang gamit, wala kang kasama. That can be frustrating, no, and scary. So we have those guidelines. So in primary care, ito yung lahat ng gagawin nung ating health worker, no? And they have to cater to all patients, all presenting conditions. So ito yung sinasabing needs-based. So hindi pwedeng sabihin ng RHU, dun lang kami sa sa minor wounds at saka cough, colds, and fever. Hindi pwede yon. So kung hinimatay, meron siyang severe allergy, dun pa rin sa kanila pupunta, a-assess nila, and then if need be, they will refer. May ambulansya sila, dadalhin doon. But they do all of this from history taking to managing patient records, including public health functions, dental services, and eye care na hindi ginagawa ngayon sa RHU. Kailangan yan provided na. And then primary care practice will be the primordial practice of all health workers, no? So and this will be defined by the ability to provide first contact care, comprehensive care for the person, which is not an organ or a problem, no? So dati yung mga doctors lalo na GI ako, gastrointestinal specialist, or I'm a pulmonologist, no? Ito, kahit sino ka pa, ano pa yung specialty mo, if you go to the primary care level, you have to be open to care for everyone with whatever problem they have. So, what does that mean? We have to have pretty good health workers with a wide range of competencies. So, these are the primary care providers, no? That will provide first contact, comprehensive, continuing, and coordinated care. At the core will be the doctor, nurse, and midwife. And for the nurses, since this was sponsored by the UP College of Nursing, the vision is to bring the nurse to the barangay health station level and partnered with a midwife. The midwife will be the maternal and child care specialist. The nurse will do everything else, communicable, non-communicable, and mental health care because of the training that we have. Makita nyo yung iba, hindi sila first contact. The pharmacist is not first contact, the PT is not first contact, but we are. And ito yung gagawin, no? Of all of those competencies, 1 to 5 will be individual-based care, and 6 to 7 will be population-based care. So, before COVID, ganito yung timeline. 2021 to 2022, finished na yung reorientation of curricula and internship programs until 2023. And then dapat mag-graduate na yung 2021-2022 batch in 2023. But this will be moved mga two years, no? Hence, but not by long. And they have to be part of the healthcare provider network. So they have to be accredited, no? Pag accredited ka, then you get PhilHealth payments kahit na sa RHU. So you don't have to be in the hospital to get PhilHealth reimbursements. Okay. So balik na tayo to the rest of UHC so that we can end. Ang susunod after human resources is regulation. We have to ensure safety and quality. Institutionalization of a licensing and regulatory system in DOH for primary care facilities. Sa ngayon, sa kasawiang palad, RHUs are not accredited. Hospitals lang ang nalalicense at na-accredit. Ang tanong ay bakit ganon? Sila naman yung dapat magbigay ng primary care. So this will change. Dapat then the healthcare facilities have to be affordable. So mamamandate yung transparent pricing of health goods. Kaya I know you have heard this halabaloo about, asking all the RHUs, ipaskill nila yung kanilang services at saka how much it will cost, no? Maraming may ayaw nun, or even the private practitioners. But that's what we are thinking to, the government is thinking to do. Equity. Basic accommodation, and what we mean by that is charity patients. For at least 90% of all the beds for government hospitals, at least 70% for specialty hospitals, and at least 10% for private hospitals. And this is, by the way, covered by a law, no? Na kung ikaw ay government hospital, you have to cater to, your bed should be 90% for charity cases. Although, meron na mga ngayon hospital enterprise that changes the rules a bit. Governance and accountability, dapat may health promotion. incorporation of health promotion and health education, evidence-informed sectoral policy and planning for UHC, and of course, very important, monitoring and evaluation. Meron ding health impact assessment. So at the end of so many years, titignan kung yung nire-reimburse ng PhilHealth ay dapat pa rin reimburse because the health technologies are moving very fast, no? And so they have to be assessed. Yeah. And then, very importantly, at the end of the day, we have to have appropriations. So source of funding for UHC, ang dami nakalagay sa law. Syntax, national government share from PAGCOR, 30% of charity fund, net of documentary stamps of PCSO, premium contributions of members, annual appropriations of the DOH, yung kanilang nasa GOP budget nila, and government subsidy to PhilHealth and other supplemental funding. So kung iisipin natin, marami naman talagang nagfa-fund ng UHC kasi people are always saying mauubusan ng pera. Parang hindi mangyayari yon. So the UHC priority areas summarize our organization of province and citywide health system, establishment of the special health fund that is so important to the health workforce, primary care provider network and primary care benefits, and the organization of APEX or end referral hospitals and public health units. Okay, so how much time do we have to do all of this? The timeline for UHC Act implementation is not too long. According to the law, we have to provide outcomes in 6 years, or else they can review the law and say that UHC did not work, let's junk it and go back to the fee-for-service whatever system. No? So wala talaga tayong masyadong time. No? COVID-19 or not, ganito yung timeline. And this is the new timeline already. No? So nung year 1, implementing yung IRR of UHC was done. Meron din tayong meron ng mga functional policies and operational guidelines in year 2, 2021, kahit na COVID. All background studies resulting in policies for financial integration should be conducted in this year until 2023 only, and dapat meron na tayong policies for funding. Pilot implementation of the global budget from 2023 to 2024, full implementation of the UHC Act in all its intended form by year 5, 2025, that's 2 years away. And merong ngayon, in year 7, there has to be an independent evaluation of how UHC has changed the lives of Juan and Juana. No? And that is where, itong sa baba, ito yung ginagawa ng DOH ngayon, yung integration in the advanced implementation sites, managerial, technical, financial, and mandatory. We will not talk about that at this point in time. So finally, where are we going? What is the health sector strategy from next year to 2028 so we can participate in the policy making? No? So this came, and I'd like to say at this point, sorry, most of my slides came from friends from the DOH with whom I've been working on this. USEC Mario for the initial slides, Mario Villaverde for the initial slides, and this one from the group of USEC Ken right now who wanted to share this information with all of us. No? So there are strategic threats of DOH. Para madaling tandaan, sabi nila, it is enable to be healthy, enable Juan and Juana to be healthy, protect Juan and Juana from health risks, care for their health and wellness, and strengthen health institutions and the workforce. So kita niyo yung special mention sa workforce. And if we're able to do this strategic thrust, the impact will be, we will have healthier Filipinos, better equitable health outcomes, and this will be responsive health system to improve not only the health, but also to ensure financial risk protection. Okay, so what do we mean by all of this? Enable to be healthy. We mean for this that citizens have to be health literate and have good health-seeking behavior. Hindi yung feeling nila sumasakit na yung batok nila, alam nilang sinabihan sila baka sign ng blood pressure pero mag-aantay pa rin ng 6 months. No? We have to have behaviors change interventions. Communities, workplaces, and schools should be supportive of healthy behaviors. So, when you say supportive, dapat merong infrastructure. Pag sinabi mong hand washing, merong gripo, may tubig. Hindi yung maghugas kayong kamay. Saan ho kami maghuhugas? Bahala ka na. No? Hindi ganon ang usapan. Protect from health risks. Disease outbreaks are prevented or managed. No? And this is where we strengthen health system structures. We will have all of these set up, the Centers for Disease Prevention and Control, the local epidemiology and surveillance, up na yan. Philippine Health Laboratory Systems, we saw that during COVID-19, yan yung wala tayo na konektado sila lahat. We will have a new Virology Institute of the Philippines and a Medical Reserve Corps. So ito yung pool of health workers, including nurses, na pagka merong sakuna or merong outbreak, pwedeng immobilize. Wala pa tayo niyan, ma'am. Kaya yan yung isang dapat gawin. Kulang na nga tayo and then may reserve corps pa tayo, di ba? Medicines and technologies are assured to be of quality, safe, accessible, and affordable. Health facilities and services are safe and of quality. Care. Ito yung network of primary care and specialist care providers. They are supposed to be of high quality and well distributed throughout the country. Talagang yan ang panaginip. And look at this, no? Yung sa left figure. And this is the tough part for health human resources. Look at these guys. Register every Filipino to a primary care provider. That is the promise of UHC. That hindi puro medical missions yung kanilang na-experience para lang makakita ng health worker. But they have to know na kahit na BHW or si midwife ganito or si nurse ganito, siya yung aking primary provider. And establish functional healthcare provider networks and primary care providers. Of course, the government and the private sector will build more health facilities and implement specific mechanisms. Care also. Quality health services are appropriately and fairly financed. No? So kung hindi afford, kahit na meron, walang gagamit nun. So zero co-payment and ensure responsive and accurate benefits developed by PhilHealth. Strengthen. Ito yung strengthen institutions and workforce. All government health institutions should be right-sized. Upgrade the capacity of health institutions, both in the public and private sector. Foster leadership in health. Ito yung isa nating panaginip. And leverage good performance. No? So we have to give grants to speed up adoption of programs and increase data literacy for decision making. So information systems. And ito sa healthcare system is implement the National HRH Master Plan. The Master Plan was commissioned by the DOH to USAID, and this was already delivered in 2018. No? So ito na yung ina-update ngayon. So to summarize, ito yung ating strategic objectives. To enable to be healthy citizens are literate, communities and workplaces are supportive, to protect our health, to protect them from health risks, disease outbreaks are prevented or managed, and medicines and technologies are to be assured of high quality, and health facilities and services are safe and accessible. Care, primary care and specialist providers are of high quality and well distributed throughout the country, and quality health services are appropriately and fairly financed. And finally, strengthen. All government institutions are right-sized para magkasya lahat, makaya lahat ng load, and health workers are adequate, committed, fairly compensated, and given opportunities for professional development in healthy working conditions na pag-usapan din kahapon. So, in summary, the enabling law RA 11223 has already been promulgated. Tapos na yon. Objectives have been set. Strategic directions have been set. Key actors and stakeholders have also been identified. So what's next? What's next is meaningful and effective implementation. All of government and all of society approach. The problem is, how do we do it all together? And yun yung isang pinag-uusapan at pag-uusapan pa rin natin mamayang hapon. And we will, the results of this discussion, we hope, will steer the discussions also at the national government as we work closely with DOH, the private sector, and the academe as well. So I'll leave you with two thoughts. No? One, which to me I have imbibed since day one. I was very excited to participate in the UHC law formulation, and I thought it was an honor and a pleasure to be part of this. And for those of us in the twilight of our careers, this is our legacy to the next generation. But you have to remember that there will be no universal healthcare without health workers. So kahit na ano pang magandang ilagay natin dito, kung walang tatao doon sa ating health system, wala rin, no? And what is that? Those of us in HRH say that we have to have the right health human resources, the right number in terms of quantity natin yun, no? Yung mga ratios, competence to ensure quality, skill mix, hindi puro doktor, hindi rin puro nurse lahat. Dapat may health team tayo with the right kind of work. Dapat may job descriptions na klaro, no? And that the work is commensurate to our training and the environment that we have. We must have working conditions, no, that are suitable for us to be able to deliver our services. So yung positive practice environments. And of course, fair compensation that values the health workers, and placement, no? You have to be distributed at all levels of the healthcare system in all areas from Tawi-Tawi to Batanes. And finally, let's learn from the Chinese who say, if you want to prepare for 1 year, grow wheat or grow rice, grow something you can eat. But if you want to prepare for 10 years, grow trees that will shade you and take care of your air quality. But if you want to prepare for 100 years, you have to grow people. And essentially, guys, that's what you and I have to do, grow people meaningfully. So thank you. If you have any questions or information, you can ask DOH, and I will help you.
Thanks, Ma'am Lynn. Better yet, if you want urgent answers, you can engage with us through our social media platforms, the UP Manila official Facebook page. You can tweet, use our hashtags, Health Workers Matter and Health Workers Matter PH 2022. We are collecting all of your questions and we will consolidate them and ask them during the open forum for everyone's enjoyment and benefit. So with that, 2025 is not far. It's just a couple of years away. Magde-December na. Do we have the right number, right competencies, skill mix, right work environment, mode work training match, and of course the placement and the distribution? So I know that we had a really good start for this morning with the universal healthcare in the context of HRH issues with Dr. Lorenzo. We still have 3 more. So now to deliver a talk on ensuring equitable distribution of health workers in the country, we would like to present to you the video of the Undersecretary of Health for Health Policy and Infrastructure Development Team, Dr. Kenneth G. Ronquillo.
Good day to all. It is my pleasure to be with you for the policy dialogue on supporting frontline health worker resilience and retention. First of all, I would like to commend and congratulate in advance the organizers of this activity and everyone here with me today. This is a very timely and relevant conversation, especially that we have been through a lot in the health sector come COVID-19 and eventually past the pandemic. Those 2 years highlighted even more the critical role of the human resources for health as the backbone in the overall attainment of universal health care in the country and, of course, its corresponding necessary strengthening and development. For the purpose of this dialogue, I will be presenting the Health Labor Market Framework for Universal Healthcare, the anchor framework of the National Human Resources for Health Master Plan 2022-2040. Then I will discuss the situation of the HRH in the country, especially a snapshot of issues and challenges across the span in the health labor market, at the entry or the production, the workforce and exit, and re-entry or migration. The National HRH Master Plan, mandated by the UHC Act, uses the concept of the health labor market, which depicts HRH movements from the production of health workers or professionals to being part of the health workforce and exiting and reintegrating into the country's workforce. Specifically, it analyzes two markets: the market for supply of health workers, which is also known as the health education market, the internal and external demand for health services and health workers, or the labor market. The health education market shows the production of qualified health workforce, including the provision of scholarships, training, and education in health. This pool of qualified health workers will then participate in the health labor market once they are employed in the health sector through any of the following career paths: non-clinical fields of practice such as health policy, health administration or public health administration, academe, research and development, and clinical fields such as primary health care and hospital care. The framework also captures the attrition of HRH due to unemployment or employment in the non-health sector and migration to other countries. The country's health system has undergone several policy reforms and organizational changes, starting with the inception of the health sector reform agenda in the year 2000 and currently through the UHC Act passed in 2019. Such reforms have brought about several strategies for HRH development. However, the Philippine healthcare system continues to face issues and challenges, especially in its human resources for health, which was highlighted by the ongoing COVID-19 pandemic. At a glance, shown on your screen are the issues and challenges identified, and this scenario actually exposes the issues across the health labor market. These are interrelated. In the next slide, I will further discuss these issues and challenges in detail. Based on the data of the Commission on Higher Education, the number of enrollees for specific health professions averages at 217,753 for the past 10 years. These include physicians, nurses, midwives, medical technologists, dentists, pharmacists, nutritionists, dietitians, physical and occupational therapists, as well as radiologic and X-ray technologists cadres. Of these, only 46,913, or only 22%, have graduated. Meanwhile, the board passers are only about 73% of the average graduates, or merely 16% of all enrollees. This graph shows a snapshot of the nurses' production in a 10-year observation from 2010 to 2021. There is a significant downward trend in the number of nursing graduates since year 2010. Observable also is the higher number of the Philippine nursing licensure exam takers, composed with a number of nursing graduates which may be accounted from both the late takers and the retakers of the Philippine National Licensure Exam. Despite the increased number of takers, The passers are still decreasing since 2012 and somehow plateaued in 2017 onwards. There was also a sudden big drop in the number of the professional nursing licensure exam takers and passers in 2020 due to the temporary suspension of licensure exams because of the restrictions imposed due to COVID-19. The issue of high attrition in HRH production or the decrease in the number of graduates and board passers as compared to that of the enrollees stems from different factors relating to uncoordinated and ineffective regulation of health workforce production. First, the actual production is being driven by global demand rather than the local healthcare system needs. The health education and training market is primarily dominated by private higher education institutions which impose high costs on the health sciences education. Such high investment in education is said to be the reason for the desire of the HRH of higher returns of investments and fair or higher paying jobs, which, if not satisfied, pushes the option for migration. To add, we have a Western-oriented health education curriculum, whereas clinical services and practices in urban areas and abroad are promoted. Considering the high demand for nurses in other countries, nursing education seems to be the most sought after health science course in the country, resulting in the uneven production of other needed cadres. That is, dental hygienists, dentists, etc., etc., etc. Another factor is the lack of collaborative planning and implementation of policies in the production of HRH. The existing guidelines lack in integrated mechanisms to monitor and share data on return service. Hence, the implementation of return service obligations that come after government-funded education is not strictly regulated and monitored. Through the years, several interventions have already been and are being implemented by the concerned agencies, including the Department of Health. These include the enactment of Republic Act 10687 or the Unifast Act, Republic Act 10931 or the Universal Access to Quality Tertiary Education Act, and Republic Act 11509 or the Doktor Para sa Bayan Act. The formulation of joint issuances to address the issues and challenges on the production of HRH through the HRH Network Philippines. By the way, the HRH Network is convened by the Department of Health to the Health Human Resource Development Bureau and is composed of 18 agencies from both the government and non-government sectors. With the Universal Healthcare Act, we are gearing towards reorientation of health profession education, curriculum towards primary healthcare, the expansion of pre-service scholarships with exposure to community immersion, and the continuous strengthening of monitoring school and student performances for CHED expansion of the scholarship. Now, the workforce, next slide please. As of June 2022, there are a total of 819,099 health professionals with valid professional identification cards. Of these, the Department of Health recorded that 39% or 387,000 are practicing in health facilities in the country, 155,496 in government facilities, and 162,891 in private facilities. Meanwhile, the data for HRH with unspecified practices and probable category of migrant health workers, which are not yet captured by this existing DOH HR information system, is as high as 60% or 494,001 of the total health professionals with PIC. The table shown exhibits data for hospitals only. Data on primary care facilities is not included. Based on available data, among the 11 health professionals, none have reached the HRH requirements based on hospital staffing standards. However, dentists, midwives, physical therapists, and medical technologists have reached more than 50% of the HRH requirements. If we look at the per cadre data, specifically on the nurse cadre, the supply specifically or currently is at 77,346, which is in fact the largest volume in the total number of HRH in the country. However, the gap in the number of nurses is still immense at 106,541 to meet a fully staffed nurse in health facilities based on hospital staffing standards. This is a computation for the 106,000 gap that will be elaborated in the next slide. In this slide, we see the computation of the 106,000 gap of nurses in hospitals, demand-wise, following the staffing requirements provided for in the DBM-DOH Joint Circular number 2013-1. The country is in need of a total of 183,887 nurses to fill in hospitals across the region. However, the supply is only at 77,346, leaving us with 106 and 541 gap for nurses. In further pursuit of determining the root cause of such large gaps, we looked at the average salaries of HRH per cadre among ASEAN and non-ASEAN countries through our national HRH master plan. As shown in the table in your screens, the Philippines is really lagging behind in terms of salary prices, with other countries being able to pay as much as 6-digit compensations. More so, there is a pay difference of about 40 to 65% between the public and private sector. Even within the public sector, the salary for those serving in the 6th-class municipalities is far from the national rate because of existing policies. This runs contrary to the aim of the government to motivate health professionals to serve in these communities. While salary or compensation is not the sole determinant of retention, the wide disparity in pay between public and private sector employment impinges on the right of health workers to have decent jobs and to enjoy the dignity of their work. This is defined in Ambition 2030 as having an income that can afford comfortable lives. As presented in the earlier slides, the number of permanent and temporary migrant health workers is more than the total number of HRH practicing in health facilities. In the National HRH Master Plan 2020-2040, such a snapshot is mainly attributed to the low attractiveness of local health labor market, where huge pay disparities of health workers between the Philippines and abroad, between national and local government hires, between the public and private sectors, and between the health and non-health sectors. Example, business processing organizations. These are evident, and you see this in Table 2. Another challenge for the Philippine government in this regard is the question of capacity to provide income to human resources for health as much as those offered by high-income countries, even hailed as a priority. The government could only hope to match the fivefold bigger than local rate offer from foreign countries considering this current economic standing. Most HRH in the country are also denouncing the lack of job security in the health sector brought about by limited to no available plantilla or regular positions and hiring through the job order contracts that do not warrant benefits, creditable length of service, and opportunities for training. Alongside such is also the varying implementation and grant of benefits and incentives provided for in Republic Act 7305 or the Magna Carta for Public Health Workers due to limited financial resources of the local government units or the non-prioritization thereof. For the public sector, there are already existing mechanisms supported by laws on the annual salary increase of HRH and the incremental creation of plantilla positions in LGUs. To further address the issues of disparities, the DOH is currently pushing for the legislation of standardizing competitive compensation, benefits and incentives in both public and private sectors at the national and local levels, and amendment to Republic Act 7305 or the Magna Carta for Public Health Workers to include private health workers. Among the other push factors for HRH to leave the country are also the lack of HRH protection and support in terms of national safety protocol or policy, provision of health maintenance organizations, accessible or limited wellness programs, and the suboptimal working environment or the lack of appropriate and sufficient health infrastructure, among others. In addition to the varying implementation and grant of benefits and incentives, is a situation that is actually even difficult for health workers in the private sector due to the absence of a national framework that provides for similar grants of benefits and their non-inclusion in the Magna Carta. While confronted with the lack of policies to include the private healthcare practice, we ensure that we are still in support of our private health workers through PhilHealth payment of professional fees. Highlighted specifically during the COVID-19 pandemic is the inadequate or inequitable distribution of HRH in the country and an even distribution of HRH workload across levels of healthcare. At the local level, local government units may face limited budget capacity or health is not their priority. As for the varying level of workload, HRH in secondary and tertiary facilities are reported to be overburdened with primary care consults, as well as the overlapping scopes of practices and an optimized HRH skill mix due to the prohibitions of existing regulatory laws. By virtue of the UHC Act, the DOH intends to address the inadequate and inequitable distribution of HRH through augmentation under the National Health Workforce Support System. Meanwhile, on the uneven distribution of workload, several initiatives have already been jump-started by the DOH. Competency and job standards for health positions are being developed and different methods are being advocated for ascertaining workload and determining the required number of human resources. The issue of low motivation brought about by the lack of career development pathways and appropriate performance measures are also among the pressing issues in the workforce. There are limited learning and development opportunities for both the public and private health workers, whereas for the private health workers, most of the training are out-of-pocket expenditures since there is no legal basis that provide for such a benefit or incentive for them. Linked with the aforementioned is also the lack of standardized performance management system or PMS and limited options for career mobility. On the career development pathways and appropriate performance measures, establishment of public health track on career progression and specialization of health professions is put in the pipeline. Currently, the DOH already offers free short-term training programs through the DOH Academy e-learning program that grants continuing professional development credits to HRH. There are also other leadership development activities, scholarship grants, and training programs such as the practice-based Family Residency Training Program and Nurse Certification Program. For standardized PMS, HRH indicators are included in the Seal of Good Local Governance and LGU scorecard. The exit and migration phase of the health labor market, based on data show about 340,423 recorded permanent and temporary migrant health workers over the years, which is actually more than the total of number of HRH practicing in health facilities in the Philippines. The Department of Migrant Workers notes that there are a total of 11,400 415 migrants, these are health professionals, recorded in 2021. It was emphasized, however, that this number is relatively small compared to previous years due to the COVID-19 pandemic lockdowns. The top three destinations of health professionals, in particular order, are Saudi Arabia, the United Kingdom, and Germany. According to the National Human Resources for Health Master Plan 2020-2040, the top destination countries for Filipino health workers are Singapore, Thailand, and Indonesia within the region, and UK, Germany, and Saudi Arabia for those outside of the ASEAN. Based on POEA monitoring, Filipinos are also bound to other countries of destination, such as Australia, Canada, France, the Netherlands, New Zealand, Norway, Austria, Italy, Belgium, Finland, and South Korea. Based on historical data gathered from POEA and the CFO from 1992 to 2019, the average number of temporary migrants, referring to physicians, nurses, and midwives, is 11,627, while permanent migrants are as high as 57,336 yearly. Looking at the data provided in the earlier slides, it is presumable that easing the HRH deployment might conceivably cause collapse in the future workforce, given the observed steady increase in HRH migration rate due to various push and pull factors, and if weak migration and reintegration governance will persist. For the interventions, the National HRH Master Plan dedicates two key result areas, specifically the KRA that talks about human resource for health welfare, protection, and career development, and the KRA that talks about HRH migration and reintegration for the overall management and development of HRH in the country. As already stated in the earlier slides, the DOH is pushing for several legislative measures pertaining to the standardization of salary and benefits of health workers, including the private sector. Further, recognizing the right of health workers to mobility and balancing it with national interest, the National HRH Master Plan also includes in its legislative agenda the review of mission-critical skills for management of health workers during state of public health emergency. Likewise, adherence to ethical recruitment of HRH through strict implementation and monitoring of foreign policy instruments is being aimed at. Currently, it is recognized that the country lacks a consensual position in HRH migration. Different government agencies following their mandates have varying and at times conflicting views, mainly revolving around deployment of HRH as a strategy for economic growth through remittances as against the need to retain HRH to sustain the country's health system. Such an issue is related with the absence of conditions in bilateral labor agreements or BLAs pertaining to limitations in the recruitment of certain health workers to safeguard national interest, just the same as the weak enforcement of monitoring of the same, including mutual recognition agreements, contracts, and other commitments. At present, it is also recognized that there is a lack of reintegration programs for returning health personnel. Existing programs only cater to displaced and distressed OFWs and domestic job categories. Further, there is also a lack of comprehensive data and weak monitoring or tracking of health personnel migration. As of this date, there are no centralized information systems and databases yet to perform the functions, which is also a factor in the underreported movement of health workers. Again, we recognize that health workforce is fundamental in building strong and resilient health systems at all levels that will ensure universal health coverage, healthy security, and enjoyment of the highest attainable standards of health. However, for these to be realized, there shall be adequate investment in all stages of the HRH, from production, recruitment, hiring, up to retention in the country. Thank you for listening and have a good day.
Thank you, Dr. Ronquillo, Undersecretary of Health for Health Policy and Infrastructure Development Team. We've now heard from the DOH. We had our great preview. Let's now go to the Department of Budget and Management to present the challenges and proposed solutions in providing financial incentives for health workers in the public sector. Please join me in welcoming the Director for Budget and Management Bureau B, Department of Budget and Management, Director Sofia Yanto Abad.
Thank you, Ms. Jen. Good morning again to my fellow public servants. I'm humbled to speak before you, our dear frontliners, healthcare workers, hospital administrators, and government leaders. We wouldn't have survived the pandemic years without all of you. I'm likewise honored to share our agenda for prosperity, which is anchored on the 8-point socio-economic agenda of the administration. This includes establishing a healthcare system that could withstand future pandemics and ensure that all Filipinos, especially those that need it the most, have access to the healthcare they deserve. We recognize that the key elements of a sound healthcare system include state-of-the-art infrastructures and technologies, seamless and digitized processes, and ultimately, excellent support to our healthcare workers, from those who strategize how to manage our hospitals and implement programs and projects that will benefit the patients, to those who do the 24/7 rounds, the treatments, and even the inventory of our hospital supplies. Towards this end, the DBM has allocated a total of 296.3 billion for the Department of Health, including the Philippine Health Insurance Corporation, under the 2023 proposed national budget. We focused on improving the capacity of our systems through the Health Facilities Operations Program with 63.7 billion, the Health Facilities Enhancement Program with 23 billion, the Local Health Systems Development and Assistance with 602 million, the National Health Workforce Support System with 16.9 billion, and the Health Promotion Sub-Program with 2.1 billion. Through this, the government hopes to ensure that our efforts to curb the pandemic will not go to waste. These programs cover the upgrade of facilities and the deployment of healthcare personnel to far-flung areas and barangays to provide preventive and curative services. Moreover, we heavily invested in health technology and R&D to stimulate innovation and encourage knowledge expansion among our health specialists. In line with this, we funded the National Health Research and Development Program with 746 million, the Health Sector Research Development with 156 million, and the Virology, Science, and Technology Institute of the Philippines with 419 million. We also aim to create supportive and inclusive healthcare systems through the National Health Insurance Program with an allocation of 100.2 billion. We hope to provide Filipinos with accessible and affordable healthcare services as mandated by Republic Act 11223 or the Universal Healthcare Law. We are targeting 12.75 million indigents under the National Household Targeting System, 8 million senior citizens, over 140,000 unemployed persons with disability, almost 100,000 financially incapable point-of-service patients, and 25,000 pamana beneficiaries. On top of this, we have 22.4 billion for the medical assistance to indigent and financially incapacitated patients and 19.962 billion for public health emergency benefits and allowances for both private and public healthcare workers, aside from the 18.962 billion standby funds under the program appropriations, hence a total of 38.924 billion, which I understand as of this week that this was further increased upon the initiative of our legislators to around 54 billion under our general appropriations bill. Of course, it is also crucial to work on surveillance and prevention, especially of communicable and novel diseases like COVID-19. Thus, we allocated 5.8 billion for the prevention and control of communicable diseases. The epidemiology and surveillance program was funded with 718 million. The prevention and control of non-communicable diseases with 2.1 billion, and the quarantine services and international health surveillance with 406 million. Other allocations under the public health program include public health management with 4.8 billion and environmental and occupational health with 86 million. These budget allocations are the result of rigorous analysis and deliberations at the budget department. Considering macroeconomic projections, we did our best to craft a budget that will forward the interest of our people and improve their quality of life amid various inflationary measures. However, when it comes to healthcare, we can cite two main challenges that affect our decision-making in terms of funding. The first and the most critical one is our limited fiscal space. The continuing health crisis, along with the other external challenges, has pushed our annual budget ceiling to its limits. We spent months evaluating agency budget proposals worth 8.66 trillion, so we can accommodate our priority programs while considering the expenditure ceiling of 5.268 trillion as approved by our Development Budget Coordination Committee or the DBCC. Still, our proposed national budget for 2023 is 4.9% higher than this year's budget and prioritizes funding for the most pressing needs of our people, especially those who belong to our vulnerable sectors. We invest heavily in human capital development, which must be accompanied by a strong healthcare system with stronger and more proactive support for our healthcare workers to help mitigate our scarring from the COVID-19 pandemic. If we value the health of our people, then we must value our healthcare workers. Last October, the DBM released 1.040 billion in addition to the 11.857 billion released allotment for the special risk allowance from September 15, 2020 to June 30, 2021 for eligible public and private health workers involved in COVID-19 healthcare response. The fund released by the DBM for SRA covers a total of 619,203 claims submitted by the DOH under our Republic Act 11494 or the Bayanihan to Recover as One Act. For the One COVID Allowance or OCA, the DBM has already released a total of 18.724 billion, covering 2,613,331 approved claims by the DOH as of September 5, 2022, covering services rendered from January to June of 2022. The second challenge that we encountered, particularly in the funding of our healthcare workers' compensation, is the difficulty in calling out and verifying the number of eligible beneficiaries, which serves as a basis of the computation of our budget requirement, considering its magnitude. Especially now that under Republic Act 1172, the coverage has been extended to non-healthcare workers and the expansion even to those who are non-directly catering to COVID-19 patients. We are hopeful, nevertheless, that in the coming periods, we will be able to hurdle this difficulty and that the processing of the HCW benefits will eventually smoothen up when the process has been streamlined and digitized. I heard from yesterday's discussion that the OIC Secretary Vergere, told the panel that one of the bottlenecks is the difficulty in the liquidation process. It's happening as required under our accounting and auditing rules and regulations. So we hope that through better coordination, not only with the DBM and DOH, but with the DOH and its RHUs as well, we'll be able to all work together to hurdle this challenge. On our part at the Department of Budget and Management, we will contribute through budget reforms that will help us track budget documents and disbursements and instill fiscal discipline among public servants. This will facilitate better decision-making, genuine transparency, and accountability in the bureaucracy. One of our priorities is the Budget and Treasury Management System, or the BTMS, which will fast-track together with the Department of Finance, the Bureau of the Treasury, and the Commission on Audit. This is a crucial digitalization initiative that will enable all spending agencies to capture government transactions on a real-time basis. With this, the spending patterns, expenditures, and evidence of disbursements will be easily accessed, paving the way for informed and evidence-based budget decision-making. We also continue to advocate for the implementation of the cash budgeting system, or the CBS, which will push for annual appropriations and obligations for government agencies. It will help address bottlenecks in obligations, which is expected to lead to on-time implementation of the government's program projects. The CBS will also foster better planning among government agencies, leading to higher utilization rates and improved public service delivery. Hopefully, through better budget tracking and spending, we will have a clearer view of what programs should be prioritized and allotted with higher budgets, and what agencies need to further work on their budget planning and spending. The services of our healthcare workers become even more imperative as we gear up for full speed recovery. We have a fighting chance at a better normalcy because they help keep us safe and well amid the pandemic. The 2023 national budget is shaped with this better normal in mind. We want an inclusive and sustainable economy that will make prosperity a common experience for every Filipino. In order to realize this, there is more that we need to accomplish. One of the first few things that we could do is to start honoring our healthcare workers, who, despite structural and personal challenges, remain steadfast to their commitment to save lives and continue to contribute to a better and healthier Philippines. Thank you, and God bless us all.
Thank you, ma'am. Thank you, Director Pia Abad. Do we appreciate the numbers? Do we appreciate the numbers? As long as numbers are declared appropriate and transparent, we are happy. Okay, let us now go to the next topic, the last input for this panel on promoting the welfare of health workers. Please welcome from the Department of Labor and Employment, Assistant Secretary for Workers' Welfare and Protection Cluster, Assistant Secretary Dominique Rubia Tutay.
Magandang umaga po sa inyong lahat. It's nice to be back in a dialogue na kasama po or pinag-uusapan ang ating mga healthcare workers, lalong-lalo na po ang ating mga nurses. Sa ngalan po ng aming kalihim, Bienvenido Laguesma, kami po ay nagbibigay pugay sa lahat po ng mga healthcare workers po sa ating bansa dahil alam po namin yung kabayanihan na inyong ginampanan hindi lamang po during the COVID-19 pandemic, kundi magpahanggang ngayon. One of the core mandates po of the Department of Labor and Employment is to protect and promote the workers' rights and welfares. And this is very fitting dito po sa ating topic na naka-assign po sa dialogue na ito, and that is promoting the welfare of our healthcare workers. So there will be three areas that I will share with you for this policy dialogue. One is on the prevailing policies and programs as it relates to our healthcare workers. The second will be the gaps that we have identified. And then the third will be some policy recommendations. Okay. So, bukod po doon sa ating Philippine Constitution and Labor Code of the Philippines, yung pong ating mga policies and programs as it relates to healthcare workers, isa po sa pinakamahalaga na sa tingin ko naisulong po or naibigay ng Department of Labor and Employment ay yun pong Department Order number 182 Series of 2017. Ito po ay guidelines governing the employment and working conditions of health personnel in the private healthcare industry. Kanina po, habang binabasa ko itong department order na ito, I was asking myself, bakit nga ba namin in-issue itong DO 182 noong 2017? I was trying to recall the incidents. At naalala ko na po, kasi nung mga panahon na yon, nagrereklamo na po yung ating mga healthcare workers, lalong-lalo na po yung mga nurses dahil sobra-sobra sa oras yung kanila pong ginagampanan. And on that same year, I think ito din po yung natatandaan ninyo, yung mga sales ladies po natin na laging nakatayo, parang maghapon. And may pulisiya din po na nilabas ang DOLE noon para bigyan sila ng upuan. Kasi yung maghapon kang nakatayo, that is really not good for our health ng ating mga workers. And so ito pong DO number 182 noong 2022 po was issued to govern the employment and working conditions of health personnel in the private healthcare industry. It prescribes the following minimum wage benefits, working conditions, occupational safety and health standards, social welfare benefits, right to a security of tenure, self-organization and collective bargaining, training and volunteer programs, and dispute resolution. So yung mga issues po that was presented earlier, pasok po dito sa DO na ito. And dun po sa DO, kung inyo pong mapapansin, there is a statement there or a provision that yung pong ating mga healthcare workers dapat 8 hours a day and then 5 days in a week. And then if you will be expected to report for another day, meaning 6 days ka na, then there must be a 30% premium already for the wage for that day. Also, we have Department Order number 198, series of 2018, and this was issued in 2018. This is the implementing rules and regulations of Republic Act 11058, which is an act strengthening compliance to occupational safety and health standards. And it provides the duties and rights of employees and workers in ensuring safety and health of all workplaces. Among others, it mandates the following occupational safety and health programs: OSH committee safety officers, OSH personnel, OSH facilities, safety and health training, OSH reports and certification, and workers facilities. Kasagsagan po ng COVID in 2021, we also issued Department Administrative Order number 46, which constituted the DOLE Technical Working Group on Mission Critical Skills, or MCS, to effectively and efficiently respond to the developments and skills needs of the Philippine labor market while balancing the right to mobility of workers. So dito po pumapasok yung migration issue. The Technical Working Group monitors the level of criticality of skills among industries and submits recommendations and strategies relative to the retention or deployment of occupations categorized as mission-critical skills. Naalala ko po, yung Technical Working Group po on mission-critical skills, ito po dati ina-apply namin sa private sector. Kasi may minsan kulang ng mga machinist na talaga naman pong kailangan abroad. And ang nangyayari, nagmamass resignation para pumunta abroad. And this is the first time po during the COVID pandemic that we are helping yung government po natin para maisulong po yung deployment cap. Kasi, di ba mas marami nga po, almost 50% or more than 50% ang nagmamigrate na among our healthcare workers. In support of the healthcare system of the country, the government temporarily banned the deployment of healthcare workers abroad when the pandemic started hitting the country in March 2020. The ban was lifted in November 2020, and the government set a deployment ceiling of 5,000 healthcare workers. In June 2021, the IATF raised the cap to 6,500 upon our recommendation. Kapag nagpe-present po kami sa IATF, dinidepensa po namin yung pros and cons at binibigyan po namin sila ng datos doon sa gap na nakikita po ng Technical Working Group. The annual deployment cap was further increased to 7,000 for this year. And there have been initial talks already recently na gusto po nilang i-increase ulit yung cap. When I say nila, dahil po ako po ay ang DMW na po kasi ang nangunguna sa usapin na ito, but of course they also consult the Department of Labor and Employment. As a member of the Human Resource for Health Network, or HRH, the DOLE also supports the development and implementation of the HRH Philippine Master Plan 2020-2040, particularly in achieving the strategic objectives of raising the HRH productivity and responsiveness by promoting job satisfaction and motivation at all levels and improve greater HRH retention. The department also initiated strategies to aid the struggles of the industry, especially during the heightened period of the pandemic. We have pledged our support to the uniformity of entry salaries, provisions of benefits, and ensuring decent working conditions. Under the Labor Inspection Program, a total of 1,030 establishments in the healthcare industry have been inspected, covering 50,000 workers, a little over 50,000 workers, with a compliance rate of 53.50%. So you can just imagine, medyo mababa po yung compliance rate when it comes to occupational safety and health. And that's not just about the healthcare industry. Other industries also, based on our findings po, mababa po talaga yung kanilang compliance rate on occupational safety and health. Kasi parang hindi tayo conscious. Makita nyo yung sa construction sector pa lang, di ba, kailangan mo ng mga PPEs, and yet, yung mga workers natin, parang sagabal pa sa kanila yung mga gloves. Alright. Also for the healthcare industry also garnered a compliance rate of 95.15% in terms of the payment naman of the prevailing minimum wage. The department demanded the inclusion of health personnel in the private sector for the grant of the SRA na kanina po, nabanggit po yon ng ating representative from the DBM. Especially for those who are already handling COVID-19 patients in coordination with the Department of Health. Labor Advisory Number 21, Series of 2020 was issued to provide compensation to private healthcare workers who contracted severe COVID-19 and recovered from it or became a COVID-19 casualty while in the duty or in the line of duty under the Bayanihan to Heal Us One Act. In the spirit of tripartism, the department actively participates in dialogues with the Hospital Industry Tripartite Council to discuss and provide possible solutions to issues and concerns raised by the healthcare workers and the industry as a whole. The Mission Critical Skills Technical Working Group has also become a platform for consultative dialogue between and among the DOLE, DOH, DMW, PRC, and the Philippine Nursing Association and the legislative branch. In terms of the policy gaps, based on the situational analysis of the HRH Philippine Master Plan, which was presented by USEC, ano na nga ito? No. Yung kanina, si Doc Ronquillo, I call him Doc Ken. Ayan. Based on the HRH Master Plan, the lack of fully functional and I would say integrated HRH system has been identified as the core of the problem. The HRH system encompasses information systems, production and deployment, planning, professional development, attractive compensation packages, management and regulation, and suitable deployment. So, in the policy gaps under the HRH master plan, following gaps have been summarized. One is inadequate number of healthcare workers in the health sector, and then inequitable distribution of the HRH, lack of accurate HRH information to guide planning and policy, limited collaboration among stakeholders with multiple roles in HRH sector, fragmented HRH governance, and unclear accountabilities, and finally, lack and poor implementation of policies. So ano po yung policy proposal ng Department of Labor and Employment? The pandemic and the economic difficulties we currently face may still be a huge challenge to all of us, and I believe that that if we work as a whole nation and as a whole society, we can ease the difficulties and provide a more decent and productive workplace. At the Mission Critical Skills TWG level, the following recommendations are forwarded. Periodically reevaluate and calculate recommended ceiling in terms of deployment of regulated professions of healthcare workers until the full system of HRH production is reached. So example of this would be the offering or the resumption of regular classes for health professions, education, and resumption also of conduct of regular professional licensure examinations. And I know that PRC is already conducting a regular examinations this year. Relatedly, include payback mechanisms that will give scholarship, training support to local pool of students in the healthcare cadres. Explore mechanisms to grant special exemption to healthcare workers who have provided at least 6 months service to the Philippine healthcare system under any healthcare facility, whether government or private, especially during the state of public health emergency due to COVID-19, prior to being allowed to leave for overseas. So this is in addition po dun sa 2 years na nire-require. Tapos, as sinasabi namin, sana magsilbi muna sila ng 6 months pa ulit. Evaluate areas of deployment in terms of their COVID-19 and other health-related burden, which could place healthcare workers at greater health risk, in addition to other standard conditions of employment contract and compliance to the World Health Organization Global Code of Practice for International Recruitment of Health Personnel. Establish additional OFW hospitals. Ito po, recent lang na nirecommend ng MCSTWG. And strengthen reintegration of returning OF healthcare workers. Are you familiar po with the OFW hospital in San Fernando, Pampanga? Have you heard about it? Okay. I'm very proud to have that hospital po na binild po ng ating, actually a private and public sector partnership po together with the local government unit. I'm so proud of it dahil po ang mga staff po natin doon, both medical and administrative, are mostly OFWs who have returned to the country or sila po ay mga anak ng OFW. And you will hear their stories. Meron pong bumabalik dahil after so long ng pagtatrabaho po nila sa OFW, halimbawa, as an OFW, nakalimutan nila yung kanilang pamilya. And they went back. They got back to the country because gusto na nilang makasama po yung pamilya nila. At I think lahat naman ng OFWs may ganitong istorya. Meron pang isa doon na hindi siya magkaanak for about 8 years. Pero recently po, nung binisita ko siya sa ospital, siya po ay 4 months pregnant na po. So, marami pong mga stories ang ating OFWs. And I'm so happy with this recommendation po na paramihin pa po natin yung ating mga hospitals for OFWs. But the DOH, I know, meron pong instruction ng ating Pangulo na maglagay po ng wards for OFW hospitals in public, DOH public hospitals. Yan. Meanwhile, with the HRH Master Plan as guide, the following strategic directions must also be pursued in the short, medium, and long term. And I think that was in the presentation po of Doc Ken. So I'd like to conclude the department statement that we really appreciate its involvement in social dialogue such as this event, as we hear firsthand accounts of emerging issues in the industry. Through these activities, we will be able to review and align policies to have their desired impact and implementation as intended. The University of the Philippines College of Nursing is one of the recognized partner organizations of the department. Please accept our thanks for organizing this policy dialogue to support our frontline health workers and their resilience and retention. As we look forward to the success of this event, may we endeavor to continue as well as embrace the challenges of the healthcare sector as a whole nation, because events like this, like the pandemic, and it's hard to predict and mostly unexpected. I would also like to express our appreciation to all of you who are here, lalo na po yung mga nasa online, who have chosen to stay in the Philippines, yung atin pong mga OFWs, and serve the Filipinos despite the challenges of the healthcare industry in the country. In support of the socio-economic agenda of President Ferdinand Marcos Jr., the department aligned priorities towards steering back the economy and creating more quality, decent, and green jobs. We will also continue to uphold full protection of labor, promote gainful and decent employment, and inclusive and sustainable growth while maintaining industrial peace. Maraming salamat po.
Thank you very much. ASEC for for Workers, Welfare and Protection Cluster, ASEC Dominique Rubia Tutay. Maraming salamat po. Busog na ba kayo sa inputs natin for today? Okay, so we had a really rich panel this morning focusing on addressing the existing issues of health worker retention. Now I'd like to call the panel to our table up front for our open forum. So joining the panel this morning would be our first speaker this morning, Dr. Feli Marilyn Lorenzo, the Director for Budget and Management Bureau B of Department of Budget and Management, Director Pia Yanto Abad. Please join us on the table up front. And of course, our last speaker, ASEC for Workers, Welfare and Protection Cluster of the Department of Labor and Employment, ASEC Dominique Rubia Tutay. So please let us proceed to the table up front. We already have a lot of questions coming in through Zoom and Facebook Live. So can we turn on the microphones for our panel members? ASEC, may we have you up front? Thank you very much. Unfortunately, our Director for the Health Human Resource Development Bureau cannot be with us, but she will be joining the focus group discussions, the roundtable discussions this afternoon. So I'd also like to encourage the members of our audience here live at the Conrad to pose your questions. Feel free to raise your hand, your actual hand, and I will call on you for questions. Just making sure, because we also have virtual audiences. We will all, in the interest of time, we won't be able to accommodate live questions through Zoom. But please type in your questions on the chat box and we will harvest all of them. Those of you on Facebook Live, we already noted some of your questions, so please keep them coming in. Okie dokie, so let's begin with our questions for this morning. The first question is, I think this would be best for any of our panel members. What part do school nurses and school clinics play in the implementation of UHC? Because Ma'am Lynn, you mentioned earlier about a multi-sectoral approach to this. What field needs exploration with regards to the role of the school nurse in universal healthcare?
Okay, thank you for that question. Remember what we said about UHC is that we wanted to promote healthy environments, workplaces, communities, homes, no? And the school nurse is actually in a very strategic position in schools to shape the healthy behaviors of students. Even in elementary, no? When do you teach them to wash their hands before and after using the toilet, or eat before and after eating? When do you teach children to choose food that they eat and to have less sugar and salt in their diet? No, that is the role of the school nurse, which in UHC will increase the health literacy of our public. No, so and specifically children, the students. And this is critical. And health literacy, as we said, is one of the primordial objectives of UHC. Can you imagine if Filipinos can make healthy choices throughout their lives? Then they don't have to succumb to early hypertension or early diabetes, or even control their weight gain very easily. No, in other countries, that is what's being done. And on a personal note, I have a granddaughter who's turning 2 years old, and her mom and my son-in-law have made it a point not to help her choose food that do not have very high sugar and salt content. And the teachers in school, she's going to preschool now in Sweden, also emphasize that thing. No, so when she comes home, she makes sure that she doesn't eat certain food, and she says, "My teacher tells me not to do this." So critical. So school nurses, healthy behaviors will be your main responsibility.
I think another aspect of that would be allocation of a school nurse. Because not all schools would have a school nurse. Usually it's just the teacher volunteering to be a school nurse, or, So where does that come into play, ma'am? Is there an allocation for that?
There are already existing regulations, no, for school nurses. There is a student population. If I remember right, I think for every 1,000 or every 2,000 children or students, there should be one school nurse. For every 10,000 population of students, there has to be a physician. So this has to be employed by the school if it is private, or the government if it is government elementary or high school or college. So may ganon. The problem is, pag walang nurse na makuha, teacher na lang ang nagiging school nurse. And I don't know if that is adequate at this point in time.
Ibang task shifting naman ata yun, no? Ibang task shifting yan. So let's now talk about the money and the allocation of workers. We have a lot of questions coming in with reference to that. Dr. Lorenzo and Dr. Ronquillo mentioned a lot about the targets congruent to the implementation of UHC. Is the DBM budget for health congruent with that plan? If you were to give recommendations, what would it be? And follow up to that also, with 2 years left, do we have budget allocated for current and projected HRH to implement UHC? Director Pia.
Hello? Yes. Talagang pag-budget, tough question, di ba? Ang hirap po. Ang sagot ko lang, fiscal space. But I have checked our records po. Based on our records, we have been able to drastically improve our budget, especially for the HRH, comparing it from 2019, that's prior to the implementation of the UHC, from around 9 billion, 8 to 9 billion, to around 17 to 18 billion starting 2021 to present. Of course, I know this might still be insufficient, but yun nga, with the prioritization that we have in the limited fiscal space, we continue to strive para mapaghanapan din kung saan natin, paano natin mapupunuan yung pangangailangan for our HRH. In the next 2 years, ang hirap, ang put on the spot.
Para kasi akong humihingi sa ninang ko ng Pasko, ninang.
Oo nga po eh. Parang baka you're barking at the wrong time. Yes, kasama naman siya sa priority natin. So we'll continue to push for that. And hopefully we'll be able to really provide or even increase the requirement for that in the coming years. Hopefully in the next 2 years. Hindi na po kasama yung 2023
Tapos na po yung budget ng 2023.
Yes, opo. Nasa ating legislative department na po.
Ma'am, you mentioned earlier about the CBS to cover you mentioned a lot of allocations to cover everything. I'm really poor in math, so I can't count all of them. But you did mention about CBS, how to cover for those just in case we don't have time for release or any delay. So what does that do, and how does it fit into the HRH needs?
And actually, our cash budgeting system is one of the many reforms that the DBM has been pushing for a number of years already, right? And ito yung isang paraan natin para maipush yung discipline sa ating mga ahensya. Kung para sa yung kanilang binabudget ay nasisigurado na yung kaya lamang nilang magastos at maubos within the period. Kasi iniiwasan natin yung wastage, diba? Gusto natin ang efficiency sa ating operations. Kasi nga po, pabalik ulit ako sa aking favorite word, because of our limited fiscal space. Ang atin pong isang solusyon, aside of course from trying to increase the revenue, which is hindi rin po madali, would be to really push for operational efficiency. And our cash budgeting system is one of our ways in order to promote that. No, para nasisigurado po natin yung pagdidisiplina sa paggugugol ng ating limitadong pondo para sa bayan.
Thank you, ma'am. Now we go to labor. Okay? Ma'am, medyo madami-dami ASEC tong tanong about labor, ha? So, when we talk about, we only have a couple of years left to the full implementation of UHC. They are really asking that do we have enough plantilla to meet those needs? Because as of present, some plantillas are not filled. And that is a mystery that we need to address as well. So, do we have enough plantilla? We recognize that if the UHC plan emphasizes the necessity of right HRH, and DOH knows the deficits, why don't we have enough plantilla? DBM and Dole.
Parang ako po rin ulit yun. Hindi ko po ipapasa kay ASEC. Dole.
Ang tawag doon, ma'am, accountability.
Yes.
And transparency.
I'm here for accountability. Ako po ang sugo. Meron po tayo ngayon ni-release recently, I think it's only last November 8, no? Yung ating revised standards or staffing patterns for level 3 hospitals, no? With hospital capacity of 200 to 1,500 beds. I think that was part of the measure of our ongoing review process because we recognize ito pong ating staffing concerns sa ating bureaucracia, which was specially highlighted by the COVID-19 pandemic. So through this issuance, I think that was only the first phase, so we can expect several other revisions that will be issued, of course, in collaboration with the DOH para po ma-address natin yung ating mga staffing concerns. Particularly for these guidelines, I think that aims to really cover the concerns of our tertiary hospitals and to address the human resource requirements of those who are under 24/7 operations para mapunuan iyon. So umpisa pa lang pero continuous po yung ginagawa nating efforts in order to address. Sa RHUs, baka po parang nasa pipeline pa yung ating RHUs.
Ma'am, this is with regards to DBM-DOH Joint Circular 3 Series 2022, ma'am, no?
So, yes, ma'am.
Yun yung for the particular bed capacities. Ma'am, I noted there that, for example, in a clinical nursing unit of a 500 bed capacity, sorry, nurse lang po yung nakita ko doon. For a clinical nursing unit of a 500 bed capacity, there are only 256 nursing staff allocated. If you remove the attendant, you remove the chief nurse, there's only 171. They go on shifts as well. So what is although we don't advocate for ratio, we want to look at acuity, the patient acuity. What was the basis for the allocation of the number of healthcare worker for that bed capacity, ma'am?
I think there have been series of consultations among different health units with regard to the setup. And in consultation also with the DOH, I think they have come up with the standards, at least the revised standards, to increase the level of our staffing personnel.
Thank you po, ma'am. There's also a question here on, ang dami kasi po, no? Give me time. Okay. So, what do you think are the major opportunities that emerge out of the current public health crisis from the perspective of your department and eventual recovery for transforming our healthcare sector? Maybe ASEC Tutay can shed a little bit on this.
Siguro kung may natutunan po tayo doon sa pandemya, ang isang takeaway po doon is really managing yung outflow po natin ng healthcare workers Kaya po maganda na laging inaaral yung tinatawag po natin na deployment cap. While we do not want naman to impede yung rights ng ating mga workers para po sa pagsulong ng sarili nilang mga kabuhayan abroad, but ako kasi advocate ako ng local employment. Gusto ko nandito po ang ating mga kababayan. But of course, alam naman po natin yung mga ibang needs. But sana temporary lang talaga yon. Doon in terms of the supply ng ating mga nurses and other healthcare workers for that matter, we do want now we have a stable supply. Laging mag-replenish din po ng ating supply that would be required of our local labor market, not just abroad. And then yung sa HRH, pagtulungan po natin whole of nation approach yung implementation. Kasi hindi lang po DOH talaga or hindi lang fiscal space ng DBM ang kasagutan nun. Lahat po tayo may pakialam para yung full implementation po ng HRH master plan po natin.
Asek, may follow-up question lang din po ako with regards to implementation of the labor laws and how we implement safe practices in the workplace. As we transition across the pandemic, increasing loss of HRH and adjustment in workloads have been leading to poor implementation of observed work hours. Some nurses who started with 12-hour shifts during the COVID time, some may implement the 12-hour shift now, but 4 times per week. So that's already beyond the 40-hour week, and doctors extending shifts. So with some improvement in working conditions, the workforce got worse, still tipping the balance. How does DOLE play a role in facilitating healthy work environments?
Opo, of course, ang unang isasagot namin dyan yung inspectorate system po natin. But we don't want naman na policing all. Kung meron pong mga facilities or meron pong mga workers affected by those kind of poor working conditions, please feel free po to let us know. Kasi mahirap din naman na parang hearsay lang. Dapat we have a concrete case so that wala naman, ang DOLE kasi one of its mechanism talaga is social dialogue. So once na-thresh out po natin yung problema ng even at the company level, madali pong masolusyonan yan, hindi lamang po ng DOLE, kundi ang suggestions manggagaling din po dapat doon sa mga manggagawa. At syempre, kailangan pakinggan din po sila ng management. So worker engagement, I believe at the hospital workplace or workplace level should be the first line of defense. At pag hindi po gumana yon, nandyan po ang ating labor inspection system.
Thank you, Asek. We have a live question from Ma'am Rosales of EMAP. Any other live question, please, again, raise your physical hand.
Physical hand. Good morning, everyone po. I have seen po these yung specific guidelines in UHC law for the reorientation of the primary healthcare, that is with with Dean Lorenzo. It has been already in the curriculum of midwifery, and as what Ma'am Pat has mentioned yesterday po. And we had strict immersion programs for the students. And it was also included in the licensure exam, the primary health care. And the registered midwives are exposed in the barangays. So sometimes the ratio is 1 to 100 maybe, especially in GIDA areas. Okay, so for me, there is already the primary health care for the exposed or has been practiced by the midwives in the areas. But the midwives are not compensated appropriately. Ayun, yun din po. And there is no, hindi na nga po sila compensated appropriately, and no midwives or another midwife or another staff to join them with the activities or the work in the areas. So how can we help these midwives? Meron na po talaga na nasa area eh. Kaya lang po parang hindi po sila napapagyaman para po sana masolusyonan natin kung ano yung po yung problema on the ground. And para po siguro they can also help the situation, yung sa global situation right now na pinapagyaman po natin ngayon yung kailangan po natin in-strengthen ngayon yung PHC para po yung mga nurses, yung mga midwives and even the doctors they will go back yung dati po, yung basic. Para po, ito pala yung kulang po natin, nasa basic pala po tayo, dapat bumalik tayo doon para malaman natin na kailangan po tayo ng ating mamamayan para kung halimbawa nagkaroon nga na talaga ng ganyang problema, which is yung naging problema natin sa pandemya ngayon, nasolusyonan na po kaagad. Ayan, ma'am. Thank you.
Thank you, ma'am. Who would like to go first? Ma'am Lynn, go ahead. Yeah, thank you for that, no. Meron tayong tinatawag na transition period, no. So itong mga pinag-uusapan natin ngayon, most of this yung sinabi ko kaninang health sector directions at saka ano yung nangyayari. Nagta-transition yan from the current situation, yung mga maraming kakulangan up to the ideal. Ano ngayon yung pangarap natin? But the things are already being in place, no? Kaya lang hindi pa nga nakikita. Huwag kayong mag-alala, yung midwives ay masasamahan ng mga nurses sa barangay health station level. Right now, there is, the UP College of Nursing is part of the leadership training for public health nurses. Pero nag-increase na rin po yung plantilla items according to DOH ng mga nurses. But these nurses will not be fielded in the hospitals just yet. Pero uunahin nila yung barangay health system and the RHU level. Kaya kahapon na pag-uusapan yung mga task shifting, yung from doctor to nurse and all that. Anong gagawin ng nurse doon sa barangay health stations at paano sila magpa-partner with the midwives? Ang plano ho, kasi kung tignan nyo nga yung na-mention na datos, masama pa yung ating maternal and child health outcomes, no? Tapos meron tayong Sustainable Development Goals commitment by 2030. Talagang kailangan ibaba yung maternal mortality at saka ibaba rin yung infant mortality below the commitments of the country kasi tayo laging kulelat doon. So, ang plano po ay yung midwife i-strengthen yung kanyang role dun sa maternal and child health kasi nga we have been unfair to the midwives in the past. Talagang nalagak sa kanila yung sinabi ni Ma'am Pat kahapon na lahat ng programs nakasalalay lang sa shoulders ng midwife. And that's unfair. So ang na-realize finally yan, so ngayon, ibababa yung nurse to do what? Siya naman ang tutugon doon sa communicable, non-communicable, and mental health issues. Kasi as we know, especially during COVID-19, lumutang yung mental health. Hindi naman natin ma-expect na ang midwife pa ang tutugon doon sa mental health. So, right now, the public health nurses are being trained for that. And hopefully, next year, bumaba na yung plantilla na yon, no? So, kinakausap na po yung mga LGUs to actually deploy the nurses that will be given to them hanggang sa barangay health station. So, ngayon, magkakaroon na rin sila ng caseload. Kasi yung nurses, the way we have to be public health nurses, no? I was an early public health practitioner. Hindi tayo tumutugon sa isang pasyente. We have a caseload of families. No? So, pupunta sa inyong may diabetes, ang responsibility ng nurse ay i-assess na din yung the rest of the family kasi pareho naman yung risk factors nila. And so, yung promise ng UHC na merong primary provider, ang bawat Pilipino, dapat mangyari na with the partnership. Ngayon, tinanong namin ho dati yan kung malaki yung barangay, pwede bang dalawa lang din sila, isang midwife, isang nurse? Ang sagot doon ay hindi. Kaya meron na silang ginagawang parang positions for certain population tawag nito variances, no? So kung malaking population mo, dapat mas marami ka ring nurses at midwives. Pero ngayon partner na sila. Ngayon, at the RHU level, may midwives pa din at may nurses pa din. Lalo na kung walang doktor. Ito yung pinag-uusapan kahapon po na sana we would have the advanced practice nurse who will be ready to do that, no? So yung screening for hypertension or screening for diabetes, kaya ba yun ng nurse at the RHU level? Dapat lang. Yung nagsusuture ng wounds, nagsastabilize kung merong accidents bago i-transfer ang patient, dapat ba nagagawa ng nurse yun? Dapat lang. Meron na ba tayong laboratory na pwedeng gumawa ng mga blood chem for NCDs at the RHU level? Dapat lang. So, sa RHU, ang kasama ng midwife ngayon, para hindi rin siya ma-burden, kasama na po yung medtech. So, that will change na over the years. Hopefully, kasi nga, maiksi lang yung ating window ngayon. And if you remember, yung reaction ng mga tao, ng public noon, ay, may UHC na, so libre na ba lahat? No, ganun yung attitude, tsaka pwede na ba tayong pumunta? Of course, kailangan natin sabihin, progressive yan, hindi agad mangyayari. But in terms of roles, yung pinakita ko sa inyo na nag-assess, nagsiscreen, nagbibigay ng treatment, ang importante is rehabilitation and monitoring of their health status. Yun ang dapat mangyari ngayon. So, wag po kayong mag-alala. We are not going to leave the midwives behind in all this. Hindi gaya noon. We do realize that the midwives have been treated unfairly in that sense, no? Na parang, dun sa primary care, midwife, kayo na lang lagi, ha? Kaya nyo na yan. Kaya tuloy, bumagsak tayo sa maternal and child health. So, let us hold hands, the different professions, so that we're able to cover every need of our patients and their families at the primary care level.
Thank you, Ma'am Lynn. We also have another live question from the Board of Nursing. Question from Honorable Divina Gracia. Please proceed to the podium. While Ma'am Divine is on her way, just want to remind everyone that after this, we will still have our roundtable discussions, and there will be a press conference at 4 p.m. through the UP College of Nursing Facebook page. So if you have additional questions, we will post it there. Yes, Ma'am Divine, go ahead.
Yeah, thank you so much for the UP College of Nursing for this dialogue. Kasi nakikita naman ninyo, nakikipag-dialogue tayo sa mga big names from DB. Ngayon ko lang. Anyway, and thank you for the COVID-19. Now I can feel, it's very palpable that I can see the regulation coming together, talking about what should be done tomorrow. Maybe today. My focus will be basically on reflection. Reflection and moving forward. My first reflection is, dati na natin pinag-uusapan, di ba? And I'm sure my good friend, Dr. Lorenzo will agree with me. We were together in CHED, and we are talking about the HRH in terms of the entry. The entry, to me, to us, is a very powerful tool to be able to give pathways to our future. Now, my reflection is, we are talking about Western education. It is true. If it's because our references are always Western-oriented references, books, journals, pati benchmarking. Mga dear friends, saan tayo pumupunta? Sa Amerika, sa Europe, etc., etc. Now, my challenge to the UP College of Nursing at this particular point, pointing to Dr. Sheila, to Dean Sheila, is how come even at this point in time, we have been talking before, now, about Western education? Did we ever get together and bring the good minds, those who are good writers, like Dr. Annabel Borromeo? I have seen her book, but it is a Western-oriented reference. She will agree with that because I have read it from cover to cover. Okay, how come maupo na tayo? Sumulat na tayo habang meron pa tayong energy to do it. Kasi itong mga nandito ngayon, I'm sure, in 3 years, 5 years, baka nakalimutan na nila kung anong medical, surgical. We are talking about mortality rate, we are talking about lahat ng mga DOH, ng mga namatay, mga may sakit. Pero how come we are not culture sensitive in terms of making the right references? And I tell you, my dear friends, because of our Western orientation, anong ginagamit ng licensure examination? I belong to the Board of Nursing. What kind of references do I use? Is it, asan ang available references ng Pilipinas? Meron tayo sa community health. But what about the rest of the subject matter? That's what I'm trying to drive at this point. That's why I said, let's reflect and move forward and come up to a more realistic journey of our. Si Lynn Lorenzo, magaling magsulat. Si Annabel, lahat yung mga tao dito. Si Rita, magaling. Si Dean, magaling. Ikaw na MC, napakagaling.
Wala
Pero,
pa kinalaman dyan.
asan ang ating production? And that is a big challenge that I am challenging the UP College of Nursing right now. The second thing that I would like to say is, hindi ko alam whether our good friends from the DBM and from the DOLE, si Dominic, kaibigan ko yan, pero ngayon lang kami nagkita. Sabi ko, ikaw pala si Dominic. Napakaganda mo pala in person kasi we usually talk only in Zoom. Sabi niya, namukhaan din daw niya ako kanina, pero hindi rin niya malaman, ako nga ba yun from Board of Nursing? Sabi ko, meeting together here is an opportunity this time to meet good friends like you. Okay. Anyway, I'd like to find out whether CPSP, kanina pinag-uusapan, maraming sinasabi yung ating napakagaling na si Dr. Lorenzo here and HRH, Dr. Kenneth, about CPSP. Ito po yung, ewan ko kung alam ng ating from DBM and from Dolly what is CPSP. Kasi yung iba, ano nga ba yung CPSP? And this is what we call Career Progression Specialization Program. Ito po yung sinasabi kanina ni Dr. Lorenzo ng Advanced Practice Nursing, which has some implication with the HRH na sinasabi natin at saka yung ating put forward natin ngayon in terms of what Dr. Lynn Lorenzo was saying in terms of our, isip ko primary healthcare. Ngayon iba na naman, yun, universal healthcare. The CPSP, my dear friend, I would like to continue with my reflection, if you'll agree with me, kasi alam ko, time is out for me. Pero, ang ibig ko sabihin, yung CPSP, lahat tayo magkakasama dyan. Hindi ho ba? DOLE, PRC, CHED, etc., etc. However, nahihirapan ho si nurse. Ako po yung in charge ng chair po ng committee on the CPSP in the Board of Nursing. Hirap na hirap kami because of looking at the overlapping of functions, looking at overlapping in terms of the scope of practice. Ang suggestion ko, again, I go back to the entry level. Bakit hindi tayo at that reflection na naman, walang CHED dito, but I am sure Dr. Annabel and Dr. G they are here, no? Kaya lang, ang ibig ko sabihin, currently in the CPSP, we have a lot of difficulty convincing other healthcare professionals. Next is pangarap. It's a dream. It's really a dream. That, again, I would like to go back to this slide presented by Dr. Ken. We are looking at, ito rin ho has something to do with Dole. Ma'am, Dominic, we are talking about top destination. 1, 2, 3 Asian. Non-Asian, 1, 2, 3. Pwede bang i-reverse natin? Paano natin makikita na ang top destination naman nung Singapore, etc., is Pilipinas? Suntok po ba sa buwan yan? And the last observation that I would like to put in is the push and the pull factor in terms of migration. Natutuwa po tayo na nagkaroon na ngayon ng mga hospital for migrant workers. Hindi ho ba double-edged yun? I'm using the word of Rita here, double-edged, in saying that, is that a strong motivation for our health workers again to go out? Because we are giving them the best health facilities in the country today. Hindi bale may mag-aalaga sa ating mga anak pag nagkasakit. Hindi bale pagbalik natin na may sakit nandun yung hospital natin. But that is only part of my, I'd like to just inject those things in this forum. Thank you so much.
Thank you, Ma'am Carmel. Duly noted, and we will also include that in our discussion later. I'd also like to acknowledge the presence of Board of Medicine Chair, Dr. Almoro. Dr. Almoro, you may also share your comments. Thanks, ma'am.
Good morning. Good morning to everyone. I'm Dr. Almoro. I'm now a member of the Board of Medicine. We have a new chair. Okay. I have a few comments, no. Si Dr. Divina Gracia naman, we are coordinating, actually, they're coordinating with us closely, and we're making fine-tuning so that we will not have questions. Career progression is actually is a mechanism to improve the level, parang PQF levels of our professionals. So for example, if you graduated with Baccalaureate of Nursing and a registered nurse, you have a PQF level of 6. So the professional training, the professional practice that we have, if accredited by the Board of Nursing, will upgrade your level to PQF 7 or PQF 8. And with DBM and DOLE, this now has a implication with salary and qualifications, professional qualifications in the workforce. So we have to understand, no, just like us, no, most of my classmates are out of the country. We have to understand that there are people who wants for them what they think is a better life. For me, a better life is in the Philippines. I work hard, but when I go home, I don't have to work anymore. Di ba? For me, that is a better life. I don't, di ba? You go
home, you
out.
don't work anymore.
When I go home, somebody has to clean the house. Somebody has to cook for me, help me cook, help me wash the dishes. For me, that's the better life. But for our other countrymen, we cannot help them from going outside. But the thing is, that creates further gap in our healthcare. For example, in one hospital that I'm in, they closed one wing because they do not have the necessary nurses, even if we've already given them a bigger salary pay. Now, if the salary pay goes up, let's say in the private, so that we can attract more nurses or healthcare professional, that's going to increase the cost of healthcare. Because you cannot give higher pay to nurses and not give higher pay to other professionals in the hospital and even the non-health care professionals. So I saw sa TikTok no nakita ko, nagpunta siya sa a patient went to the ER for chest pain and she had the bill of 11,000 for a few hours stay there. Lord. So that's half a million, more or less. So the reason why in the Philippines we have a little smaller fee for health care, no, is because of the salaries and the everything else. Although for the standards of Filipino, that's a little high. Okay, so if in our hospital we increase the salary to compete with others, that's going to increase the cost and maybe unbearable for our countrymen also. So we cannot compete with international countries, and we cannot also prevent them from going outside. Diba? I cannot prevent my classmates from going outside, but some of us stayed here in the Philippines. Okay, so that's one thing, no? So in as much as we want to cap the people going outside, that also, but you see, it's not going to bring money here. Why? Because the offer is bring your family along. So when the nurses go out of the country and they bring their family, they don't have to give remittances to the Philippines anymore. Okay, so that's one. Number two, my other question, no, I wanted to tell ma'am, no, I have a friend, and this just happened this year. So I have a friend who works for the government. He's a doctor, and because there's a new governor, he's not anymore a doctor in the government. So if you want this to work, all sectors have to be in. All sectors have to be in to provide quality health to our people. So it just not cannot be PRC and CHED and DOH. LGU has to be there because the healthcare system is already devolutionized to their level. So if the current political leader goal is not healthcare primarily, then the healthcare of the people will suffer in that community. So there was a provincial director, no, medical director, asked me because he was telling me that they do not have much funding in the hospital. So I was telling him, illustrating to him, if let's say, for example, your pharmacy has a budget of, for example, 10 million. In 1970, the 10 million will fill the pharmacy, meaning field of medicine. At the current price today, maybe not even half for the same budget, and the budget is not changing. So less than half, one. Number two, you have more people availing of government care. more population, more people in the locality. So that's a very big disparity. So hopefully our policymakers will see that and will. So it's not about also. It's not about there's not enough doctors. It's not managed well. It's just inflation and population and yun. Thank you.
Thank you, Dr. Almoro from the Board of Medicine. Now, we need to cap our discussion, unfortunately, but let me cap it off with the last question, synthesizing from the comment of Board of Medicine and Board of Nursing. Now, this is my last question for all of our panelists. In the context of UHC, how do we achieve better health work environments, better compensation for our HRH, greater numbers, without passing on the financial burden and increasing the out-of-pocket cost for healthcare?
Okay. One of the things that we have mulled, there's a UHC study group at UW Manila composed of actual practicing faculty and retired faculty. And our convener right now is Dr. Ernie Domingo. Before he passed on, Kwasi Romualdez was with us. So we've been thinking about this. Our dream is to have a tax-based healthcare system. So that, and in some progressive countries, that's what's happening. No? So you don't have to beg for funds anymore. But it's part of the tax that you will ask all citizens to pay. A good example of this is what the socialist countries, the Nordic countries, are doing. No, they have a very high income tax rate, as high as 60 to 70%. But all their services are provided for by government. No, so healthcare is free, education is free, housing is free. Education from kindergarten to college is free. So, alam mo yon, masakit yung taxes mo because your paycheck becomes lowered, but you see the services. Tapos, you can bank on the government to provide those services at high quality. Case in point, even the drugs, the pharmaceuticals that are availed of by the citizens is purchased by the government and made available to Canada's the same. The National Health, the NHS in Great Britain is the same. So our dream is to really shift from the financing schemes that we're having, because then because of inflation, the fiscal space becomes smaller. But what if, as incomes rise, if our economy gets better, then we are able to contribute more. So walang financial burden doon sa patient because nakukuha na dun sa tax niya. Now, the other kalaban natin, and I think this is the big elephant in the room, is of course corruption. When the tax is paid by each and every citizen, dapat pumunta doon sa dapat patunguhan. So I think that's another question. But how will we make that happen is something else. But we feel strongly, the UHC study group feels very strongly that if we can shift to a tax-based system to finance UHC, that might help.
The rest of the panelists?
Ako muna. As for the DBM, as I have mentioned earlier, basically yung gusto natin is i-push further yung transparency, accountability sa ating budget. Para with this kasi, despite the limited fiscal space that we have, we are able to allocate more funds dun sa necessary na priority natin, which is dapat yung health. So we have a lot of areas of improvement in identifying the leakages yung mga wastage that we have, no? Tignan natin yung ating procurement, tignan natin yung ating logistics management. Kasi kung ano yung magugugol dapat doon na nasasayang or just lumilipas na lang yung iba, 'di ba? Na imbes na ilalaan natin para sa ating mga healthcare workers, 'di ba? Sayang naman. So if we'll be able to push for that, for us sa DBM, hopefully dun sa ating dinedevelop na BTMS that would enable us to have real-time information on the government transactions. It will be able to promote transparency and accountability and thus help really push our agencies na i-ensure yung kanilang discipline and operational efficiency to reduce wastage.
Thanks, Ma'am Pia. Yes, ASEC, Tutay.
Siguro tatlong bagay po. Unang-una yung education at the very basic level. Kasi doon pa lang dapat yung mga bata na mamold na natin for a healthy lifestyle. Ngayon, nagugulat kami, 30 years old, meron ng mga sakit. So kung may sakit ka, di ba, madideluge mo yung healthcare facilities natin. So dapat nag-uumpisa sa atin. Pangalawa siguro dahil dole kami, we want to build that culture of health and safety. Para din ma-unburden naman po din natin yung ating mga healthcare workers to take care of us. We should also take care of ourselves para yung working conditions naman po ng ating mga healthcare workers, hindi naman po ganun kagrabe ang maranasan nila. And finally po siguro, as I was sharing with Director Abad kanina, yung prudence ng paggastos po natin ng budget ng pamahalaan. Kasi we've seen cases na may mga pina-purchase tayo pero hindi na natin nagagamit kasi na-expire. So, strategic planning, careful planning, and foresight siguro, dapat meron po ang bawat isa sa atin. Thank you.
Thank you very much, everyone. Can you give a round of applause to our panelists? Thank you, Dr. Feli Marilyn Lorenzo. Nabubulol na ako. Thank you, Director Sofia Yanto Abad. And thank you, ASEC Dominique Rubia Tutay. Maraming salamat po. So, thank you for everyone who has participated actively in our live stream today, for using our hashtag Health Workers Matter, and hashtag Health Workers Matter PH 2022. You may still post your questions and we will summarize them. We will ask our panelists later at around 4 p.m. for our press conference. This will be live streamed through the official Facebook page of the UP Manila College of Nursing. So for this afternoon, we bid you goodbye, our virtual attendees, as we do a roundtable discussion this afternoon on policy options to retain health workers. So with that, on behalf of the UP Manila College of Nursing, a WHO collaborating center for leadership in nursing development, ably supported by Johnson & Johnson, we bid you goodbye, and please watch out for more postings on the policy dialogue. Thank you very much. Okay, inaanyayahan po ang ating panelists to
Recording stopped.
This QR code for the certificate of attendance upon completion of the evaluation form. So again, thank you very much for attending the National Policy Dialogue, supporting frontline health workers' resilience and retention during the pandemic and beyond, led by the UP College of Nursing, World Health Organization Collaborating Center for Leadership in Nursing Development, supported by Johnson & Johnson. Okay, let me reiterate that by 4 p.m. today, we're going to have a press conference live stream through the UP Manila College of Nursing Facebook page. So if you still have some questions that you would like to ask, you can still post them through the live stream comments. Just put the hashtag Health Workers Matter and Health Workers Matter 2022, Health
Recording in
Workers Matter
progress.
PH 2022, and we will summarize those questions for the press con later on. Okay, so thank you very much and have a good day.
Recording stopped.